We all look fantastic. It's not about your outward appearance, it's what's inside.
That's what they all say.
Um, all right, well, how is everybody doing? I mean, so far it's just you two, and
Yeah. Oh, we had a code the other day that was in SKU 2.
a
So I don't
code.
know if
You've
you.
had like 15 codes the other day. Let's be
All
real.
right.
SKU two. Let's talk about SKU two right now. What's happening?
What is happening?
Too? Like
No,
downstairs?
like you guys, the
No.
Or
MICU.
upstairs? I don't know. It's a zoo.
Yeah, but
I've never, like 3 days in a row last week, I was just like slammed.
Yeah.
There was like, you'd sit down to just document one little I and O number, and it's just like, JK, gotta go running into the room.
Oh,
And then the amio infiltrate,
Yeah.
that was interesting, but sad for her, but I think she's fine.
Yeah.
But it was just literally one thing after another, and then it's code.
Yeah.
Excuse me, it was just blowing up.
did you put the medication in? I've never had to do that when something infiltrates.
Yeah, I don't remember, it was like hydrogenase human, something like that. And it's like 6 shots that you put in the perimeter of their arm with sub-Q needles.
Interesting.
And it actually works because it was actually the amio infiltrate, because we were wondering, is that what caused it? And you could see the discoloration getting so much lighter after I gave
Okay, how did you know I infiltrated? Was it just like red?
It wasn't even red. So her AC was indurated, and I felt it was like, ooh. And then, but you like look down her arm, and it wasn't even just like a red, warm spot. It was this like snake of bruise looking colors that went up her arm, but then around the snake purple color was blanched white, like ghost white.
Holy crap.
And when who? What'd you say?
I just said, holy crap, I've never seen that.
Oh, yeah.
Do you know how long it had been like
seen it.
that? Like, was it pretty
No.
instant that it was noticed?
It was it was on the bottom of her arm. So when you look at the top, you don't see it. So 8 a.m., the IV was looking good. So it was between 8 and 12 that it caused it, I'm pretty sure, because the IV started leaking. So I was like, I don't want to have amio on this IV anymore because it's leaking and that just looks kind of sketchy. So I went to move it, and then I moved her arm and was like, it infiltrated. But none of the residents knew that amio was harsh on your peripheral veins, because I asked for a central line in rounds because of the amio, and they're like, "Just posh, Ashley."
Yeah. It's supposed to be run centrally.
Yeah,
You had
well,
a filter on it, right?
Huh? Yes, I wrote a Carl note. I wrote a note. It was a whole tobacco. I was so sad, but she came out okay.
And then the medication worked, did it like totally go
Yeah.
away?
The induration was still there, but the discoloration got significantly better. And then I learned about the Rovers phones that we use upstairs now.
Mm-hmm.
Yeah, those are cool.
It was a pain in the butt, but amio goes not through a peripheral IV. And make sure you tell the new residents that, because they all say they didn't know. And then right after rounds, I went in and was just like, damn it.
And then you pooped yourself a little bit.
I pooped myself and then was like, if we're running the amio, we gotta have it.
Yeah. It's one of those things, kind of like with Levofed or something. It's like, if this is the only access point you have, use it until you can get the proper access. But if they were just kind of like, yeah, whatever, that obviously needed to be addressed. Also, it was a MICU patient, right? So, was the fellow aware? Like, was he attending? Meaning, like, did they know that this was being run, that they were going to continue running this,
Yeah.
and this was the access that you?
And they all said it was fine.
Okay.
Yeah, and they all said it was fine during rounds. And I said, not what I've heard, but okay. Like,
I thought
and
it was
then
like 12
right
hours we'll accept it
You know,
or something.
like way over 24.
when we were downstairs, like the way we look up policies is terrible. Like, try to ask for a policy and go find it, and you just can't. And the appendix like C whatever it is for our IV drips. When we were downstairs, we used to have like those old silver charts, and we used to have a bunch of laminated copies of certain things that we would, different, like the SAS score would be there, and pupillary checks and the different dermatones, and then there was this appendix that was in there for most of the medications, and how often you had to do vital signs, and which areas of the hospital it was okay to run these drips and whatnot. But I believe it had that information about central access, and I remember like in the vasoactives, I believe it said, if greater than 24, you need central, but peripheral's okay for 24 hours. I don't know what it said about that, but what I'm getting at is that I don't know where we have a quick accessible copy of that like we used to do in downstairs. So that'd be like something that maybe if someone can find the appendix buried in our our like electronic thing, that maybe we can like print off a couple copies for each of the sections and have it laminated and just
So all of the nurse educators, can you guys hear me? We all took drugs and rewrote that entire appendix last year that went through the main health policy, whatever. But I do know, because the policy website that we used got an update, and the update made it even harder and worse. But we did sign a contract with a new company that we're going to move all of our policies to, that makes it easier, like a whole different system.
Nice.
That Natasha got, that it won't be here till the summer. So at least there's that. But yeah, I can try to find the appendix that we looked at every single med and rewrote that appendix that you're talking about.
Nice. Yeah, it would be helpful for just like these types of occasions, right? And now you can sort of just be
And
like,
Ashley had asked for, which is a good idea, is like what color tubes do you need for which labs? Like we used to have those old posters and stuff. And so I reached out to the manager of the lab, and they are working on one, because each company has its own like different tubes and different things. So that the lab, Nordex lab people are working on that as well. So look at you.
nice. Speaking of lab draws,
You have one, Josie?
Where she had like a list.
oh,
Yeah, I just made my own one time and like made little flashcards at the very beginning just to remember.
Well, I call lab actually every single shift, I swear. I mean, not obviously with the basics, but there's always just some random lab tube that they chuck in. And I'm like, I don't know.
yeah, and definitely call them. I mean, they'll know. The other thing that I think would be helpful on that list of labs is, they've always been able to do this, but I think in the most recent couple of years, Patty Ulrich definitely was sort of making a push for ABGs, because ABGs can house a lot of different labs that you don't need to run a whole separate lab for. So like you can get a lactate off an ABG, you can get this critical care electrolyte panel off an ABG, but what actually comes with it, I don't remember. And that would be nice to say, okay, if one runs an ABG, here is the list of things that you could obtain if you needed them. You don't have to have them, of course, but it saves them, especially if you're sticking them, or even just accessing repetitively on their A-line, those are, so having just like what could be incorporated within the ABG would be really helpful, I think. Because I always do try to minimize blood draws as much as possible, retime if things aren't like super important and need to be like precisely drawn at a time, okay, wait 1 hour because this one's going to be drawn over here, so let's just do all of those. Maybe they're in the same color top tube. Maybe it's a lab that they want. You got to think of strategy this way too. Maybe it's a lab that they want, but it doesn't necessarily mean they have to have that information from right now. So in other words, let's say like 4 days have gone by and no one's checked a phosphorus, and they put in a phosphorus now, and they had an 4 a.m. phosphorus, or BMP drawn. I don't need to know what their phos is this minute. I just need to know what is it today. So just add that on to that draw, and you don't have to stick them again. Just kind of like that stuff. Whereas, their PTT is very time sensitive. I need to make sure I know what it is kind of now, or where's their lactate right now. So.
Did you say something about phosphorus in when someone's on a ventilator?
I might have suggested
Yeah,
like
Mark, I think you did, because actually yesterday my patient's FOS was 2 and she was having trouble CPAPing and stuff, and I was like, huh,
yeah.
maybe I should replace her FOS.
Yeah, like not. Yeah, I was gonna say what I might have referenced is that you need it for every cellular function. You need ATP, right? So the P part is your phosphorus, and so if you don't maximize their phosphorus level, that things as simple as their ability to breathe might be something that you can see. So if it manifests in such a way where you're seeing their breathing pattern, is you're like, why can't they do this? They should be able to do this, and then that's the one thing that kind of sticks out. It's not their TSH level. It's not the fact that they're over sedated or whatever. That it's just merely, hey, their FOS is a bit low. Let's give them some extra. And then I don't know what you saw out of that, but maybe you saw a huge improvement or a subtle improvement in their CPAPing. But when you asked that question, I was like, when they're ventilating, I don't know what you mean. But then the reference point.
Sorry.
Yeah. No, that's okay. I figured that's what you were probably referencing is,
Because my patient the last 3 shifts, so this week, had suspected refeeding syndrome, so the FOS was just chilling at 2. I mean, his lungs are kaput. They're no bueno in the beginning. But I was wondering while I was in there, I was like, because I was giving K-FOS, I was thinking, I wonder if this is what
Totally.
Mark was talking about. I mean, he wasn't trying to CPAP. We're not even close to that, but
No, but that's the beauty. Like you are thinking of this is what critical care. I mean, this is what every nurse does, right? But like we're in a critical care setting, so there's like so many other layers that we're trying to think about. And yeah, we're not just robots at the bedside hanging stuff at certain times and just doing. We're part of this team, and you're thinking, and that's what I want for everybody is to be thinking, because as a team, not you don't. It's not just because they're a doctor, they're always going to know everything, or they're going to remember. Hell, they apparently didn't know that amio was supposed to go through a central line, but knowing like, oh, okay, these are the things that are important for good function here. Oh my God, I've been seeing that their FOS is low. Oh, I'm noticing that they just don't seem to CPAP. Well, could this be part of it? Well, why not maximize it? If they're in renal failure, you're obviously going to go the opposite direction. Your FOS is probably going to be like 12, which we don't want either. But when someone has okay renal function, normal renal function, and then all of a sudden you're saying, hey, their FOS is like 2.0 every day, and we know at least 2.5 is the bottom of 2.6 is the bottom of normal. 2.5 is where you replace. It's like, all right, well, let's just do this. Let's maximize them from this angle, right? One more thing. If it was like they're a bad COPDer and they have a lot of inflammation, maybe they sound tight and wheezy, maybe giving them a steroid would help maximize them to achieve getting off the ventilator, right? But in this instance, it's like, okay, maybe you've done that. So that check, okay, what else have we checked? Okay, we've lightened the sedation so they're not like hypoventilatory. So we're like, check. Okay, what have I, I'm seeing that this FOS is like chronically low. Ooh, let's push that up and let's see. So absolutely does that make sense? And you're thinking about it, and that's like, to me, like, whoa, for you guys to hear you say like, oh, you said that, and then you're telling me this back, is like, it makes me so proud that we're all doing this together, because I just feel like I want to teach as much as I can, but also hearing the fact that it's actually benefited. It might sound cliche to say that, if one person gets this, but out of the blue did Josie write me this text message and was like, I could just see her now with her hand on her hip going, okay, this is why this happened with the whole PEEP thing. And I was just like a little tear came to my eye, It's meaningful to me. It's really meaningful. And so, I always say, like, I don't have all the answers, but if I can help in any way, this is what I've always wanted it to be, just something organic and have a nice conversation. And hearing this back, like, I don't want to just be the only one talking. I love hearing like this. You had this thought, you heard it from here, and then you applied it, and then it made sense, and something good came out of this, or maybe something bad, I don't know, but something came out of it, right? So I'm very appreciative to hear that feedback and that you were thinking of those things. So thank you for sharing.
I feel like when you're in COVID and you're just stuck in a room,
The wheels
you
are
do a
turning.
lot of just troubleshooting of actually anything and everything
Yeah.
for hours, and then you're just like, why is nothing I'm doing right now
Helping.
working?
Yeah.
Because this poor guy was able to oxygenate, but he wasn't able to ventilate, and then he would become desynchronous. He's a disaster.
Yeah.
We'll figure. Well, hopefully.
Yeah, it's it's really great, and like just think of all the different aspects when you have a problem in front of you. The doctors are thinking about what happens for differentials, right? Like, here's a person that the respiratory failure. The differentials for that patient make sense because this could be the problem, this could be the problem, this could be a problem, but it's so unlikely, so we're not even going to mention it, right? So they're strategizing in their head what makes the most sense to this patient in this situation in front of me, right? And so at least this is how my brain works, and it's all from just learning over the years, hearing them talk and kind of making sense out of it. It's like, okay, this person can't get off the ventilator. What else could we be thinking about? What else could we be missing that we're not doing already? Maybe, oh, yeah, like we said, the steroids, check, they're done. We've got them. We have them on this amount of pressure support. Their sepsis is over. What else is it that we can think of? And something as simple as just kind of going, wait a second, their FOS has been like 1. Or we haven't had a FOS since admission. This happens a lot. Sometimes they're not here for, a certain problem that requires you to figure out that information, a basic lab. But when someone's sitting in your ICU for a while, for me, I'll be like, okay, what do I have today? Okay, this is low, I'll go replace that. When's the last time they had this? Where has this been? Because I just think of like the 4 electrolytes in my head constantly, right? Like every morning, K, FOS, MAG, and the iCal. As we've talked about before, if I haven't rattled this off and suggested this about 1,000 other times, I don't care. No one really cares about what your total calcium is in the ICU setting. I mean, I'm sure there's application for that in certain settings, definitely as an outpatient, because no one needs to have a specific iCal. But when we're talking about the ICU, I want to know what's ready to go right now to do the job for clotting, for vascular tone, helping with your heart and contractility, contractions. So I just kind of think like if it was yesterday they had a MAG of 2.5 and nothing's going on with their, we haven't like over diuresis patient or something. I'm like, I probably don't need a MAG today. Or, hey, they've been here for 5 days and I don't even see a MAG ever drawn. I'd be like, oh, I want to know. So usually, this is being recorded. Usually, I don't even bother asking them, can I draw a MAG or do you want? No, I just put it in myself and just usually say protocol. I don't know what protocol. You probably can't even find it if there was, but so let's be real. But it's one of those things you think about, like what is really just sort of basic. And the other benefit, like we just talked about, this kind of goes all the way around, circling right back, is that you are talking about labs and trying to figure out, how many labs do I need and can we just get them all grouped up together so I don't have to access them or stick them 1,000 times. And if I've seen like, hey, this patient had 4 a.m. labs and no, there was no FOS, no, there was no MAG, and they've been here for like 3 days, I just kind of want to know based on what I heard in report and what I've even seen, I can just go add that on, and then I just call Nordex, give them their E number, and say, can you add this MAG on to this morning's BMP? So I don't have to have them stuck again, and it's just a really quick, easy way to just see, like, are we okay? Especially when people are saying, oh, they had this electrolyte, or they had this, like, ectopy here and ectopy, and I'm like, has anybody even, like, looked at all the other ones? It's just something, to me, those are really, really simple ways of trying to sort of figure your patient out. It's like you're being like a detective just as much as the doctors, It's not just you're in there turning and feeding meds, but you're kind of thinking like, I'm sniffing something out. What is the problem other than poop? What is that problem? Okay, they've been here for 5 days and they just can't get off the ventilator. Wait a second, has anybody checked a phosphorus? When is their last phosphorus? Oh, shoot. we've been refeeding them. Oh, they're an alcoholic. Oh, they probably never eaten a meal in their life in the last like maybe couple of years or something, because all they do is drink. And we think about refeeding syndrome on somebody like that, or somebody who's just malnourished from a different reason. Maybe it's anorexia, or just maybe they just haven't eaten because they've been sick for so long. And it doesn't always have to be one of those types of problems. It could be somebody who has cancer that's maybe getting chemo and just can't eat and can't eat and can't eat. And someone like that, what do I think about right then and there? As words just came out of my mouth, I'd be thinking about dronabinol. Can we stimulate them to eat? Unless they have a feeding tube, that's a whole different story, because now you're just kind of forcing it into them. But someone who maybe could potentially eat and just trying to stimulate them to eat, but the same things would hold true. You would think about, hey, this person probably hasn't eaten for days and days because they've been feeling so crummy. Now they can eat, but they don't ever want to eat because they don't have an appetite. So what can I do to help stimulate them? Dronabinol, or Miranol is the other name.
What is that? What does it do?
It's the non-THC version of marijuana. It's like in a pill. And so, it's something that physicians can prescribe to help try to stimulate patients to try to eat a little bit.
Okay.
Yeah. It just doesn't
So what happens in refeeding syndrome that we really worry about? Can't your levels then they plummet or something?
So
So
yeah.
what I saw, your K drops, your FOS drops, your blood sugar goes up.
Oh, I thought my blood sugar went down. I don't know.
Yeah, no, it's so your blood sugar. So basically, think of it like this. Like I always try to describe your body. It's from whatever's happening to your body, whether it's a trauma, sepsis, heart attack, whatever. Right? Your body is always trying to achieve homeostasis in some capacity. So when you're now looking at like just a feeding portion of their entire body, right? If someone is sort of underfed for whatever reason, all the ones that we've just listed, right? You think about their whole body sort of slowing down so that it matches like supply and demand, right? So if they're not really ingesting enough nutrients, and then their body's saying, well, you're not feeding me well, so I'm just going to sort of slow down all of my processes, right? So in the cells, everything's just kind of slowing down. Everything is still working. It's just slow, right? So they're hypometabolic. And then it's like, okay, all of a sudden you just like open up the dam and you allow all the good nutrients that they need, right, in a day. And all of a sudden their body's like, whoa, we need all of this and we haven't had it for so long, and now you're giving it to us. So then what happens is metabolism starts to increase. But right now, in relationship to where they were, they're going to start chewing through stuff in order to generate, heat and their cellular metabolisms and all of these processes that they all do. Like every cell does their own thing, right? But they're all working and they're all utilizing stuff. And the big ones you see is like their FOS drop, their MAG drop, their sugars can actually plummet because, they were having gluconeogenesis until they couldn't do it anymore. So sometimes if they're really profoundly underfed, maybe, and again, depending on their process, if it was like an alcoholic, I would think more so than maybe somebody who's just not eating from chemo. But you think about where the how much sugar do they have left in that little sort of like refrigerator, i.e. like their liver, right? So it's stored in there, and then when they actually need it, because they're not ingesting it, they break it down, right? But at some point, they can't do this anymore. They don't have anything left. So that's when the catabolism of fats and things start to occur. They're feeding off of their own proteins, their own fats, but now you're looking at giving back all of the nutrients. And then remember, ATP is sort of that thing, that the fuel source that the cells are looking for, and they utilize different aspects of what you ingest in order to create that, right? And then utilize that for energy. So they use something and shift it from one form of energy to another, and then that's their fuel source, this ATP. And if you remember the P portion of things, that's adenosine triphosphate, they end up making but using, right? So then in relationship to where they were, they might have had like a low, maybe borderline normal phosphorus, and then you go and whack them with all this good food, and then all of a sudden their metabolism everywhere, just like all the cells start to just utilize it, and everything sort of just plummets. So that's what you're looking for. It's nothing other than looking at really like the electrolytes and making sure that for a certain amount of days, and it's a little different for everybody, but a couple of days, maybe 2-3 days, maybe 4 days, I don't know, where they're not able to have food before. Now you're giving it to them, and all of a sudden you watch all those electrolytes kind of plummet, and then what you're doing is you're trying to replace them and keep on top of them until homeostasis occurs for that point in time, right? So now you've sort of given them back what they need, and then finally they hold a steady state, and now they're back to what would be like a normal metabolism, right? So now hopefully all the electrolytes stay normal because now they're using them in the normal sort of supply and demand. It matches what's happening right now, you know? Does that make sense?
Mm-hmm.
And you know, another group that, you know, in my unit is somebody who has an ileus or, you know, gastroparesis, and you just can't feed them, and you try and you try and you try, and you put two feeds in their gut, and it just doesn't go anywhere. And then the reason now, as the sniffing it out, why are they not having things go south? You know, I might be turning over this patient and thinking, you know what, they've been here for a week and they've been on 4 Dilaudid, and maybe, you know, they've been getting their Miralax and Docusate and all this stuff, and we need to like make this stuff go from here to there, right? We need to make it move south. And something like, okay, we've given them lactulose, we've given them X, Y, and Z, and nothing has made this person poop, which means everything's staying in their stomach that you put in there. And then, of course, we're siphoning it right back out, or maybe they vomit a lot, and then we have to put them back on suction. So basically, all the food source that I keep giving them doesn't go anywhere. So they never get it. You know, yeah, it's in their stomach, but it doesn't go anywhere. That's it. That's this last stop, it's stomach, and then what next? Nothing. So they're not absorbing anything, and you're stuck. So over time, that can turn into, you know, malnourishment, right? And so we need to sort of like try to fix that. So while I'm turning somebody, I'm like, maybe we have to try methyl naltrexone. Maybe it's just this opiates, you know, the opiates that are causing them to have, you know, this constipation and poor motility and stuff. Or maybe it's just something based on a surgery, and maybe, you know, it's not, maybe it could, sometimes it could be mechanical. Maybe there's something that's like pressing inside of them. So sometimes they'll have to open up their stomach, or sorry, their abdomen, in order to, you know, get in and move something out of the way, or decompress, or, you know, whatever. Maybe there's a kink in the bowel, right? An adhesion or something like that, but way up high or something. So anyways,
that was actually that was on my list of questions today. Was actually like about an ileus.
yeah.
I'm just like, do we do intermittent section? Do we do trickle feeds? Are we feeding them? Are we not? Are we using Reglan? Like,
Yeah.
because I feel like we don't see that as much, and you guys probably do. So can we talk about that a little bit more?
Absolutely. So I will definitely talk about that. Does what I just talked about, or is what I was saying about refeeding making sense? Okay.
It does.
So when you think about, like, you know, ileus, so how, you know, how I was got taught and how I think about it is that anytime you sort of like muck around near the bowels, they just sort of like freeze, you know. And it can take anywhere from a day to 3 days. I mean, obviously sometimes it can take even longer, but generally speaking, it's like 1 to 3 days where bowels sort of kind of come back and motility starts to happen again. So the thing that I always encourage people to do is, when it comes to having NG or OG access, or even something like a PEG tube if they happen to have it already, or something like you know, like a gastric tube that's not a PEG, but like, you know, temporary, could be like a red rubber, not that usually goes there, but just something that's not quite normal, but something that's sort of in their stomach, and you're thinking, okay, well, if I have access to it and I know things aren't going south, intermittent suction, especially for the NG and the OG, I think is obviously the way to go, because it does a couple things. It doesn't put a lot of stress on the stomach. It will siphon out hopefully everything that's in there once you kind of get everything kind of down and out, right? So usually when I first get a patient, I'll crank up the suction all the way and have it on continuous, just so I can get everything out of their stomach. Once I've seen, okay, nothing else is coming, I usually separate it and then reconnect it just to make sure it's not like thick. And then once I know, yep, I think that everything has been siphoned out, I will turn the knob back down so that it's at, I always say this backwards, but it's the bottom of the green, which is the top of the suction on that level of the green, the rainbow. And so have it kind of down there, and then I put it on intermittent. And how I think about the intermittent is that you always have you have a couple things working for you, right? So the big thing is that you have a sump. So some people don't understand what the sump is. So if you think about a vacuum, if I were to have a closed space and then I just vacuum out that space, eventually I collapse all the walls and I get nothing else, right? But that could be a giant hickey to the stomach. And so you could cause some injury to the stomach if, let's say, it kind of grabbed on a certain area and maybe they had gastritis already or something, and so you're trying to kind of limit injury there. So the sump is allowing air to kind of come back into the circuit so that you never fully suction or vacuum close their stomach and cause like an injury there. So you want to hear that little whistle. Sometimes it gets clogged. And what the anti-reflex valve is what that little guy is called. That's like blue and green and blue to blue. So the tubing that comes out is blue, and then the white part is what hits the air. And so if you ever have lost one or just have to change it and you get just a little anti-reflex valve, just remember blue to blue. It's easy. And then what that allows is air to get drawn in through those little tiny holes, but it doesn't allow the fluid that might get pushed back out. So if a patient coughs and stuff kind of goes up and it goes up into that side of things, it doesn't come out and like fly all over you and the bed and the patient and all that stuff. So anti-reflex valve allows for air to keep coming in while you're on suction. So really you're just looking for the fluid to kind of come out. And it doesn't matter if the patient has an ileus or not. The bowels are always, your stomach is always making about 1 liter, sometimes up towards 2, depending, but usually around 1 liter to 2 of gastric fluid every day. So this is why sometimes like, well, if they're not eating, you're not putting anything in their stomach, where's all this stuff coming from? Because they're just still making it. That hasn't stopped. You know, those little cells are still dumping in that acidic fluid. It just now it doesn't have anywhere to go, so eventually left untreated, if it were to build up, now they might start getting distension, nausea, and sometimes they don't even feel the nausea, it just comes right up and out, and next thing you know, they puked all over themselves. Obviously now you worry about aspiration and things like that. So having the intermittent suction, when it's on and actually suctioning, the anti-reflex valve is allowing so that you have air and you don't fully vacuum seal your stomach in. But the other thing is that if you were to have one of those little eyes of the end of the NG tube sort of get near some of the tissue and kind of like cause like a hickey effect, is like how I describe it, having the intermittent knob on, you allow for it to hopefully release and then maybe move somewhere else, so that you're not constantly, if you're on constant suction and it finally found a little spot, it's just constantly there. So if you never give it an opportunity to let go and move, then that's a potential for injury. So and then there's other aspects like I think stimulation and things like that people like physicians tend to think about, but generally speaking, that's how I look at intermittent. So again, I just sort of like set it up with full suction just to get everything out of them, and then after that I will put it on intermittent, and I put it just sort of to the bottom of the green, which is the top of that section of suction. Well, that's a tongue twister. So with the Reglan question, it again, I always say this to people, it's with every pill, or there's an ill for every pill, but there's an ill in every pill, right? So if a patient might have a non-mechanical obstruction with, it's just gastroparesis, and just they need something to tell the nerves in the pylorus to like wake the hell up and move and move stuff from up here down there so it can go through the tunnel, then that is probably a great option. But then you have to consider the renal function, so it has to be renally dosed. And then also, you think about other effects, and this one tends to push up a QT. So if you have somebody who has a prolonged QTC, it's one thing to kind of think in your brain, okay, I'd like to try this drug, but can I? It meets all this other criteria, it's not a mechanical obstruction, so I think that, let's consider this, but what is their cardiac, what's happening with their QTC? Do we have a recent EKG? Or even just something as simple like, our EKGs on our monitors, when you go and do your quick strips in the morning, those are always a great ballpark. They're not like 100% precise. The EKG would be that much better, But if you're getting like a very obvious low number or a very obvious high number, I would take it in consideration and be like, okay, if they were like 3.2 on my monitor, I'd be like, yeah, their QTC is fine. No problem. I wouldn't even think about going to ask anybody for an EKG. But if it were like 4.8 or something, I'd be like, hey, if you want to start it, maybe just get a quick EKG. Or maybe they're already 5.2 on my monitor. So I just definitely want to know, what is the show? The other thing that gets tricky is your rhythm, right? So like if you were in AFib, to really get a proper QTC on our monitor is difficult because you don't have, I mean, you're trying to use what is consistent timing to give you what is the QTC, because there's an equation that I don't even remember. I just know it has a square root in there, and I don't even remember how to do that. But you have a long equation, and thank God there's a quick button you hit, and it just does it all for you, but it takes your R to R. So we know in AFib it's like not regular. So what do you do there? So my style is I kind of like take a segment that's on the screen. I kind of sit back and say, what seems to be the most consistent thing about here? You know, you have some maybe quick ones and maybe some wide ones. But hey, these ones for the most part look about the same. So I'm just going to like substitute this in for my R to R, just to quick hit this quick button and get a ballpark number for myself. And if I feel confident, like, oh, 3.2? Oh, sure. No problem. Like, I'm good. But if I was like higher up into the high 4s or then obviously the low 5s or 0.5s, then I would be thinking, can we just get a quick EKG? Because I feel like that would just be the most proper thing to do for the patient, the safest thing to do for the patient. I don't want to just, I think so, but I don't know. And then obviously you have a torsades event after, right? So you have to think of those things. So, you know, it's a good drug. But, you know, obviously just like anything, it comes with its problems. So, and then, you know, people can then, if let's say it works really well, then maybe the adverse effect after that is that maybe they start pooping a lot, which, hey, they need to. That's kind of like the nature of the beast, right? Also, you know, we use it kind of like, not its like main feature, but an antiemetic, right? Because if I have a patient that's having all this distension from an ileus, then potentially they're going to start getting nauseous unless they just kind of projectile vomit without the nausea. But if they get nauseous, then you know, this might be something that obviously helps with gastric emptying, so that distension won't be there, therefore the nausea hopefully won't be there. So it has this antiemetic effect too, so it kind of can hit a few birds with the one stone, so to speak. So and then, you know, the big thing is really just trying to stimulate the bowel. So maybe it's not just gastroparesis. Maybe it's, you know, something lower down. Maybe it's a combination of these things. So you have to think like this isn't happening and down here is not happening. And oh, we did a KUB and it looks like they're FOS, nursing diagnosis, right? And so we need to try to help them go. So it's maybe, you know, giving something up here to help push things this way, but also maybe it's something down here to help change, like, you know, the osmotic gradient within their bowel and trying to get them to have a water slide eventually and then stuff come out, and trying to push and pull kind of thing, or squish and push as Betty likes to call it. So, you know, giving a lot of Docusate and Miralax and things to really stimulate, irritate, and hopefully keep things on the liquidy side. And then down here, maybe suppositories, maybe the infamous milk and molasses enema. This guy right here, a lot of them recently. And really trying to get things from down south to kind of move through, you know. Maybe it's gastroparesis and a bowel obstruction, or maybe it's gastroparesis and maybe they had surgery near their bowel and they're just sort of like frozen, right? So not maybe a surgery to the bowel, but something that's kind of near it and it irritated them. Or maybe it's just their bowel and it has nothing to do with gastroparesis. So maybe things are kind of going here, emptying, but now they're getting stuck down here. I don't know. So it's kind of like targeting what is the problem, obviously, and then maybe using certain medications to help with that. And you always want to try to start with like the benign things, right? If I could just have to give you Docusate, not methyl naltrexone, great. It's cheap and it's probably one more safe than the other drug, right? And I know it's way cheaper. So, but then, you know, maybe you try these things and days go by and still nothing happens, and then their belly looks like it's getting bigger and bigger and bigger, and you know, now you got to try to figure out how to get that stuff through. And that could be something that eventually could lead to someone needing an open abdomen if really you couldn't do it, you know. if you really, really have left days and days, I mean, but everybody's different, so there's no real time frame on this. But we've had patients in our unit for like 10 days without a bowel movement. No one's going to surgery about it, but you were like trying. But here's the thing, circling back, are they actually ever getting fed then? Are they really just sort of like getting, hypometabolic because day after day after day, you are just not able to feed them properly. So then when the day finally comes and you are able to feed them and maybe not ramp it up quick, but whatever, but you might start seeing a decrease in all those electrolytes that maybe once were looking kind of stable and now, they're all kind of plummeting, right? And that right there. So if I know like someone hasn't been fed for a while, I just kind of jump to in my head somewhere refeeding syndrome and just like, hey, where's the recent phosphorus? So this just kind of circles back to the original question, right? So and then the feeds. So one thing that we try to do, if someone has like obviously a large content come out, and let's say they're on suction and they have a liter come out of their gut, or maybe just over the course of a day they've had a couple liters, but maybe not at one time, just a lot of output as hours keep going by. You worry about all kinds of things. You're siphoning out electrolytes, their blood sugars are probably going down, things like that. But we try to stimulate their digestive tract. We try. So we call this trophic feed. And what I've learned is that you have this brush border around your whole. You have this brush border around your intestinal tract, right? That's like the first thing that everything is touching all the way around, and so that needs to be sort of stimulated. Think of like atrophy for a muscle. That thing, if you just don't do anything with it, if you don't stimulate the digestive system in that capacity, just a little bit of something, it weakens. And then what we worry about is translocation of bacteria from the gut into your abdomen. And then you get maybe a peritonitis of some sort, sepsis. And then who knows what happens after that? Do they get super sick? Does it go somewhere else? Does it now get in their bloodstream? Is it a lung infection? I don't know. But the point is that they know, as we've passed on and just reciting this information, is that you have this brush border, this little, I think they're called microvilli, I think is from pulling stuff from the back of my head. And what happens is that if you stimulate them by just giving that little bit of food, just that little bit, so they have something to do. It's kind of like occupying them, and then what happens is their integrity stays a bit better, and therefore you're less susceptible to having this sort of complication after that. I don't know of other complications. I'm sure there might be some other ones, but the big one that I always remembered was the translocation of bacteria if left untreated. Or if you can't stimulate. So, but the thing is that's the point, is sometimes you just can't. You try, and we try day after day. And let's say one surgeon is a little bit more willing to test the waters than maybe a different surgeon, or medical patients. This doesn't just mean surgery. You can take this whole conversation, right? And you can flip it over to your patients, right? Somebody who's septic on multiple pressors. People are very, very wary about trying to start any sort of feeds, because once you put food in your gut, you're sending the message to make your stomach want to turn and move, and it's demanding blood. And when you're already having ischemia happening all the way around your body, and now you're trying to divert, not a lot of blood to your core and then to your stomach, that might be grounds for further ischemia, another event. Maybe it's to your whole intestine because you just can't get the supply, And so if days go by where the patient's so sick and on pressors and people are still unwilling to test the water with that can lead to the same problem. That is not helping with the integrity of that bowel, by sort of even giving that trophic feed. So for you guys, don't think of it just in the surgical world, but you can apply this to all of those types of patients. I don't know for, what you guys would do, let's say in the neuro world, about holding two feeds. I don't think that's probably a common thing, because unless it's like a nausea thing, I'm not sure you're having a procedure or something that's occurred where people are a little bit nervous or skittish to push food into them. I'm sure there's processes that you would worry about that. But generally speaking, I don't think you're having to deal with that maybe as commonly as we are. And then maybe second to that would be the MICU. But having the patients basically being starved because of another process, are you losing that integrity? And how many days do you worry about losing the integrity? And I think it's after at least a day you start worrying about that. But again, you try and you try and you try. Sometimes we have to then consider, again, provider preference, and I'd say surgical, medical, whatever the provider, but at what point do you then consider TPN, as your alternative? Something also, just because this is for nutrition, but again, you're not feeding their gut. So, but other things to consider as being helpful for the patient that maybe isn't like fixing this whole problem by any means. But sometimes people like to go, okay, wait, you do have propofol up there. You're getting some fat calories, so you're not completely starving them there. And if, a sugar is an issue, maybe low for just not being fed, or maybe they have a liver injury, and then coupled with this, or just the liver injury alone, whether it's shock or maybe it's cirrhosis from, bad choices over the years. But maybe they put them on just something as simple as a D5 something drip, or just D5, or the D. We need the D, right? So the D is what's going to help. Maybe it's a D10, D20, who knows, But you're giving them a sugar, maybe from propofol they're getting a fat, but we're missing the protein. So where do they get that from? Themselves. So we always try, and again, everybody's comfort is different. Even in my specific world, surgeon to surgeon, you hear different things, and every surgeon's right? So all of them are right, so the other one's wrong. But there's things to consider, like when you are on multiple pressors, especially if you're going up on them, do you want to feed their gut and demand blood there when they can't get it to their finger or maybe to their heart? Maybe let that kind of go for a little while. Which makes sense, but then at some point, when are you considering doing this? And then some people say, if they're on just a little bit of pressor, well, what's a little bit? To you, a lot, a little bit there? I don't know. Everybody's different. Some say if you're not refractory anymore, so you've gone up and now you've held a steady state. I'll reintroduce it. Some are like, if they're on a pressor at all, no. The answer is no. So it's like, what do you do? So you advocate. You have to ask the question. And sometimes you ask the mom-dad question, right? Mom didn't give it to you, so let's go ask dad, or vice versa, right? So maybe you have one surgeon on this day, but you're working 2 or 3 in a row, and then a different surgeon comes in, or maybe you really feel like the patient should get it, and they're actually doing better. And so sometimes day to night attendings or whatever, you might be like, hey, they didn't want to do it here, but what are your thoughts? What do you think? And they get to make that decision. So just because you didn't do it here doesn't mean you can't do it here. And I'm not saying to do this just always for the right thing for their patient, right? So like just not just saying, well, I heard in this lecture that Mark said, like, definitely try to get them fed no matter what. So ask no, whatever makes sense. I don't know what the right answer is, and I'm not sure anybody really knows what the right answer is. So I think it's where they've been practicing and what they're comfortable with, right? Now, I'm sure there's some studies, some literature out there that supports a little bit of this and a little bit of that, but some of the basic physiology makes sense, right? If I am going up on pressors, I probably don't want to put something in there if I really can't push enough blood around as it is to the other organs that are definitely life-sustaining. Like, yeah, maybe I don't get, I get a little bit of infarct to my bowel. Maybe I can cut that piece out. This sounds gross, right? But I can cut that piece out. But their heart's okay. Maybe they have to have a resection to their bowel, but their heart's okay. Their lungs are okay. This is a sucky thing that happened after, but at least those things, and you're alive, and that's what you wanted, I hope. So, does that speak to your questions? Is there more? Is there something else that you're thinking about? You're on mute, by the way. Okay.
Well, if we just want to keep going with bowel stuff for a hot second, I had a patient that had a rectal tube in for like, I don't know, maybe 10 days at this point or something, and he was still getting scheduled, Miralax, DocuState, and all that. And I've heard some people say you need to keep giving the bowel med so that it gives you the consistency. But then some people say, like, heck no, we're trying to get that rectum tube kind of out as soon as possible, so stop. What are your thoughts?
Okay.
What's the right thing to do?
No, it's a really great question, because what you're trying to consider is like, why do you have the rectal like device in place for the first, at first,
Okay,
right?
fair.
So like I'm going to just talk to my side first. So a lot of times, not always, but I would say the majority of the time, we have somebody with a complex wound, and so I don't want them pooping in their wound, because it's not okay, right? So in that instance, do we mostly put a tube in, and we do want to keep them liquid, because we want obviously the stuff in their bowels to be able to make it through the tubing if it was a solid poop, which who in the ICU poops solid anyways? Is there anything really but a 6 and a 7 on that Bristol's chart? No, I don't think so. I think it's only people who live at home have those. But those guys, they have these really, really complex wounds. And so to poop in them is not okay, right? So those are the patients where back in the day, like years even before I started, they used to do a lot of ostomies, so diverting ostomies. But then they're like, this isn't okay practice. Like, why do we need to do that with all of those complications? Then we could just try something else. So it's kind of like, just let them poop and it's on the nurses to deal with that. But no, now someone's invented these devices, which are great. And so you can stick this in their bottom. And just so it's clear, they can leak. That doesn't mean, I'm just going to say this now, that does not mean you go add more water, okay? I have pulled out balloons that have had over 200 cc's in them. That's not okay. That's like 45 cc's. So if you tug it back like a Foley catheter and it rests on the inside of the second sphincter and it's like this and something leaks through, that's okay. But the majority is probably going through the tube. You just clean them up like you normally would, but you only have a little bit to deal with rather than a lot. People just think that, oh, it's in, they should never leak. I should always have a dry flow below them. No, that's not the case. Would that be great in a perfect world? Absolutely. But that doesn't mean you just go inject a little bit more. If you want to know if there's enough, what you do is you leave it inside of them. You don't touch it. Okay, you take that, there's an irrigation port and a 45 cc fill port, and you take that port and you grab a 60 ml syringe, you screw it on, and you draw it out, and you see, oh, maybe there's only 30 in there. In that case, drop some more, and it doesn't matter, it could be tap water, it does some form of liquid, and you draw it up, make it 45, and re-inject it. Before you re-inject it, just because if you're already doing all this, you might as well do one more little thing. Just take your finger, put some lube on there, and just make sure that it is past the internal sphincter, not the outside, the internal, right? So think of if you. Okay, so if anybody doesn't understand this, at your own leisure, we won't do this on camera, at some other point in your time, in your life, if you like to do this, you take a little bit of something and take your finger and you put it in your own bottom, and you feel that there's the outside sphincter, but then there's the internal sphincter. So it's like a canal with two doors, okay? And so the inside one, you want it past that. Sometimes it gets pulled back and maybe it's just resting in the canal and you want it beyond that, right? So if I think, oh, is this even in the right spot? While I have it deflated, I'm going to take my fingers, put some lube on there, and just make sure and try to push with my fingers and feel and make sure that it's scooted way past the internal sphincter. And then I'll inflate it with the 45 cc's, and then I will pull it back, just like a balloon on a catheter, right? Once you get it in the bladder, you kind of just gently pull it back until it meets that resistance, and it rests there, right? So same thing, you're gonna want to just sort of pull that thing back, and then hopefully it just rests in that little spot, right? And now it has just 45 cc's, and if it's, leaking, it is what it is. But majority is coming through there, hopefully, right? And sometimes, if it's been in there a while, their tone might be a little bit down, so maybe that's why they're having a little bit more. Or maybe they're coughing a lot, and it doesn't matter that the thing's there. It's like, and it kind of just shoots out in all these directions, right? So, so if you're using it to try to protect the wound, absolutely do we say, okay, we want to keep this thing liquidy. Now, let's just give an example to the burn patient. For a while, it's like we do that, right? We do grafting maybe, and we want to keep that underside nice and clean. Then maybe after the grafting's done and maybe some time has gone on and we feel like, okay, now we want to start to normalize them. This thing is adhered, it's looking good. Now we want to start to normalize them. So what we do is we then make our plan change. And we're saying, okay, no longer do we want to keep it liquid. We're going to keep the device in, but here comes the guar gum, right? Now we're going to go the full 180. Now we're going to start to thicken them up. Now we want them to have this weird mystery like Bristol 2-3 that I've never seen in my life. With my patients, let me just point that out. But we want them to like start to thicken up. When it starts to look like it's thickening up for the tube, and you kind of like having to milk it along and stuff, then that's kind of like, all right, should we take it out? Just so we know, it's FDA approved for 29 days. So it can be put in for 29 days and left in for 29 days. We do usually have to give a break, and then we can reintroduce it. One of our previous complex burn patients had one in for a while, kind of like lost tone, and then we gave a break for a while, a couple weeks, maybe 3 weeks. It was kind of like a crappy week, literally a crappy week. And then we ended up reinserting it, and he had a little bit more tone. But something like that you can consider for a long time, right? Sometimes these are just a couple of weeks. Now, if someone is here because we've given them a ton of antibiotics, right? And we've tried the guargum already. We're not trying to thicken them up. I mean, keep them loose. We're trying to thicken them up, and they're just pooping everywhere. And maybe they're starting to have some injury to their tissue. And this, maybe you talk to the wound care team and say, hey, I'm really thinking that this might be the better thing until we can get them thicker. Then that's not what you're trying to do. You're not trying to keep them liquid. You're trying to thicken them up. So that's a different story. The thing that always weirds me out is the C. diff. We put it in for C. diff, but aren't we just sort of harboring the diff? But I will tell you what's beneficial for having one of those tubes in if you have this uncontrolled C. diff where, maybe you have them on Flagyl, it's not working, and then you start the Vanco oral and it's not working, and then they say, let's do some Vanco enemas. I will say, and this actually is two things at one time. Vanco enemas for that particular population, or let's say you had a patient with really bad ammonia levels, right? Not anything for a wound problem, but ammonia level, and they want to do a lactulose enema, and they're all very, very frequent. What you can do is use this device because it has this little clamped system that usually is left in the container once we put the device in. It's like this purpley looking like jaw thing. Kind of reminds me of girls when they put that thing in their hair, a little with teeth that's long. Anyways, it clamps it. And so what you could do is you can take the irrigation port and you can instill their Vanco enema or their lactulose enema, clamp it, and let it dwell for 30 minutes and out, whatever they want, right? And then you let it go, and hopefully, if all the stars line up, all that stuff, including whatever might be in their bowel, comes back through the tubing. Maybe some of it leaks, I don't know. But, and maybe because it was clamped and maybe they coughed a lot, some squirted out, whatever, no big deal. Please don't just add more water to the balloon. Make sure it's okay, make sure it's properly inflated and in the right position. But, you want to, or you are able to use that system to sort of dwell those kind of those products. So like the Vanco for maybe the C. diff patient, or maybe you have the patient with really, really bad ammonia levels, and you're giving them lactulose up here, it's just not doing the trick. So now you sort of just dwell this liter or half a liter, whatever, 250 of lactulose into their bowel, into their rectum, and then hopefully release it, and a lot of stuff comes out. And with that, their ammonia level might drop, or their C. diff looks better. And then same thing, you're trying to like maybe thicken them up, or maybe this is all just related to a bunch of antibiotics. Some people are just sensitive to their tube feeds. Like people have never had, fiber in their life. You put them on Gevity, and then all of a sudden they're like, diarrhea city. And it's just from the tube feeds, or a combination of all of this, So you can thicken it up, you can keep it loose, but why are you doing it? That's the question. It's the why are you doing this? So if it's just because they're having diarrhea and you just need a way to protect their skin and this is the best avenue, then you are trying to hold their Miralax and Docusate and Senecot and maybe actually be giving them the guargum or whatever, Metamucil, I don't know, whatever we're giving these days. I know guargum is the hot thing going right now. But then if you're trying to protect a wound, you might be giving all of that stuff and then maybe some more, right? To try to keep it all loose so that you can kind of protect that wound, and then eventually you might go the opposite direction and then start to thicken them up, right? So.
Right. That makes a lot of sense.
Okay, good.
Yes.
I'm glad.
I shouldn't have given Miralax the last time I had that patient.
You shouldn't have. No, and that's, I mean, it's okay. I mean, it's like, did you hurt him? Probably not, probably not. In the grand scheme of things, a little bit of extra Miralax when you're already having diarrhea is like, oh, just more diarrhea. But let's think, right? We're not going to stop there. What then do we want to consider? Ooh, what are their electrolytes? Have we been pooping out our bicarb? Right? So things like that. It's not something as simple as just giving Miralax and that's the only outcome you had. What other things have you screwed up? Good job, Josie. Just kidding. I'm totally kidding. But I mean, most likely it's potentially just harmless. Like they pooped a little bit more. So, the symbols. I forget you can do those. I'm still not very good with Zoom. So,
What is it?
the smiley face or the crying. Because my jokes are so great. But so hopefully that makes sense. Are there any other questions surrounding these topics?
It's on my list.
All the poop list. So we talked about refeeding syndrome. Talk about the ileus. Gastroparesis, some of the meds. Talking about the methyl naltrexone. So I don't have like an actual dollar figure, but what I do know is that methyl naltrexone is considered an expensive drug. I want to say, and I can't remember off the top of my head, I want to say it's 12 mics. It's a sub-Q injection. And how Gil Fraser, I miss this man. To you, Gil. This goes out to you. But if it was going to work, it's supposed to work in 4 hours. So if they have not pooped, kind of that 4 hour time frame. So after that, you're like, all right, they didn't work. That being said, there are times to consider a repeat dose. And I want to say you up the dose, kind of like, I know this is a weird connection and they're not the same, but like adenosine. So like if you were to give adenosine for just try to stop the heart to see what the rhythm is, you give 6, and if that didn't work, you give 12. I think of this the same thing. Like if the bowels didn't really respond to the first dose, I can't remember if 6 is the first and 12 is the second, or if 12 is the first and 18 is the second. I don't know. I can't remember exactly. But there's like kind of like 2 doses you can add in a second vial. But I can't remember exactly the dose off the top of my head. But it's one of those things where, it's competing for the mu receptor in the bowel. And it's so this isn't meant to make it so that they're not feeling pain anymore, or sorry, that they are feeling pain, like a Narcan thing. It's sort of higher affinity for those receptors in the bowel, so therefore they don't have that kind of constipated effect from all of the opiates that they might have been getting. And then all of a sudden it's like a giant cathartic. It's like, blah, everything kind of wants to slide out. And I've seen it where, you give it and almost instantaneously these people kind of poop. But then I've also seen people like down the road poop. But generally speaking, 4 hours is sort of like, okay, they didn't poop, I gave them that, so do we repeat it and give a bigger dose, or do we just kind of like, now we're on to the next thing, And I know it's not the first thing we would want to think of, but it is something to consider when you might have been giving this Senokot and Miralax and Docusate and all this stuff over and over, day after day and day and night and day and night. Maybe you added in lactulose already and that still hasn't had anything. The dam needs to be broken, and you don't want to be the one to do it, but it's going to happen. And then maybe no one's thinking of it, so maybe in your back of your head you're like, okay, a lot of opiates and maybe methyl naltrexone. And if you can't remember that name, just the poop shot. Maybe think of it that way. I don't know. Hopefully someone on the pharmacy team will remember what the heck that's called. Not to be considered with methotrexate, or confused, with methotrexate. Methyl naltrexone. And just thinking of, okay, maybe this is opiate-induced constipation, and this will help let them go. Free him up.
That's not the drug that we get really nervous about their heart rate and have like atropine ready, right?
No, that's neostigmine, which I always find really funny because before this new in vogue drug called Sugamidex, so I don't know about you guys getting patients back from the OR and paralytics being used, but like in the surgical side of things, they go for a procedure, and not always, but a lot of the time they come up relaxed, as they like to say. they've been relaxed. But sometimes they'll reverse them with something called Sugamidex, which is going to sort of counter what the Vecuronium was doing, or the Rocuronium, one of those oniums that they're using downstairs. And so it used to be neostigmine, but it could have these side effects. But here's the thing: is they were reversed with neo. They were reversed with not neophenylephrine. Just so we're all clear, a lot of things called neo, right? But they were reversed with neo, and I've never heard anybody coming back from the OR in asystole of some sort, right? But then you go through all of these drugs to get somebody to poop, and then you worry about neostigmine causing asystole, right? But what I might consider being the adverse effect is not necessarily the drug alone, but maybe they have something really, really dry in there that's finally coming through. And guess what is also in the bowel? Anybody want to take a guess? That might cause what you're thinking about as your adverse effect. How about the giant vagus nerve? Right? So you slide down, maybe they Brady and go asystolic because a giant dry turd just fell out of them. This is why sometimes people have a lot of MIs on the toilet when they're trying to strain and they push and then they vagal down and they do all kinds of bad things right to their heart. But kind of considering maybe that angle of it is not so much as the drug itself causing that. Another thing that just since we're talking about this topic is a few weeks back I did see an email. It used to be that anybody who was going to get neostigmine for their bowels, like not having constipation, and they were anywhere else in the hospital, they always had to be on telemetry, which means they always had to come. So you might have a transfer into the ICU just to poop. Isn't that funny? But now there's a new policy that says that they just need to be monitored, and I want to say the physician has to do it, and they can be anywhere in the hospital as long as they're on telemetry, I want to say, or if they have, I don't know what the duration of monitoring is, but I do know there's an email from Chelsea, our pharmacist, out there saying this, and I don't know if the whole unit got it or if it's the coordinators that got it. But that is something new in the last few weeks that they changed their policy. So I think the doctor has to give the dose on the floor, and then they do have to be monitored. It's just the duration I can't remember, so I can see. I'd have to go back to work and see what the email said. But that's a change because everybody used to have to come to the ICU to poop if they needed it, which was not a common practice, right? Like it wasn't like you were getting one of these every week or something, but it's just when you sort of exhausted all of the other things, is this the next thing that you can do? So, yep. Neostigmine. Also interesting, neo used for other things. It's funny, we reverse it for our paralytics, right? Might make you poop with it, but also we can use it as the old Tensilon test for myasthenia gravis, if anybody's familiar with that disorder. So autoimmune disorder. So when you talk about that specific disorder and what's happening is, destruction of the acetylcholine receptors between the muscle and the nerve, and the nerve is trying to spit out acetylcholine, and you don't have enough of these receptors. They're broken, they're damaged, and so the muscle can't really contract. So these guys, they come in with basically all of their muscles being weak, so they might not be able to breathe well. A classic hallmark sign for these guys is they get like ptosis of their eye. And so the old Tensilon test, I don't know if they do this like I was taught years ago, and I don't know if they use different agents now, but when I learned this, it was neo, and you give it a little dose, and all of a sudden, like instantly, you would see like their eyes like open, like they can lift everything, they can move, and it was like, this is another way to diagnose that particular disorder. And so you're inhibiting the breakdown. So these are acetylcholine esterase inhibitors. So this is why if you look at what Vecuronium and Rocuronium and all the oniums, what they do, they're working on that same spot, right? So they're not like damaging something. This is just like a chemical change to say I'm in the way of the acetylcholine. I'm breaking this down. I'm not allowing this to be used, right? So kind of like a beta blocker in a way. but for this particular receptor, and then you're trying to reverse it by the enzyme that would break down acetylcholine. You're trying to inhibit that enzyme so that there is an abundance of acetylcholine near those muscles near the motor end plate, where the nerve is, or the nerve, meets the muscle. So reversing the oniums and make you poop, and helping to diagnose myasthenia gravis, or at least it used to be. Can't say what it does now. Maybe still. I learned it as the Tensilon test. I don't know if anybody had heard that. If, in case people aren't hearing what I'm saying, I think that's how. Maybe one L. It might be one L. I'm a very bad speller. Tensilon. I feel like it's one of those two spellings. I don't remember. So, but that was like specific to that autoimmune disorder. So, good. We talked like almost an hour and a half about poop. And refeeding and stuff like that. So that's great. It's a good conversation. I'm just going to check my... Oh, I have no idea what that was. Joss wanted to come. Hope that would be me. I apologize. So I'll let you guys think of another topic that you might want to talk about. She just had a couple of things that she wanted to talk about, if possible, unrelated to this topic. Just at some point I might bring it up. But do you guys have anything that you're, feeling like you guys want to talk about or add into this conversation?
How do you know? Okay, so I kind of learned, like I said, being in COVID world, I have been stuck in rooms, and I don't know why I don't get what presser they use and why.
Yeah. Okay.
Like the different pressers. Like I don't know, I feel like everyone uses Levo, and then I get like the side effects is that it can cause like, it is alpha and beta, right?
Mm-hmm.
And then Neo is just alpha.
Mm-hmm.
But I don't know why it doesn't click. I feel like everyone's like, grab Levo.
Yeah, so...
I don't know how to, like, I feel bad that I swear I asked these questions like 1,000 times.
No, so the beautiful thing, no, first off, ask, and if it takes 1,050 times, keep asking. There's nothing wrong with having it not sink in. Like, if you can remember every single thing that you were ever taught, you're superhuman at this point. I can't remember endocrine, and I taught the class. And I don't remember what I even taught. So
I think you did really well in that class.
Thank you. I appreciate it. But it's one of those things where it just doesn't stick, and you don't think of it like that all the time. So, you'll probably have, just as time goes on, you get more and more familiar, and eventually things will be like these kind of like aha moments that sort of stick inside of you, is how I put it. And I always kind of go back in time about learning drips, trying to kind of, in a way, memorize them. Try to be familiar with them, but you have to kind of memorize it first, just to kind of say, oh, this is what this should do. Okay, but I used a lot of swans back in my day, which it's you're not seeing them as much really ever. And then what we have is a substitute or flow tracks, but there's some very similar information you gather from that. But what I felt like is, it's great for the patients. It's kind of like how I always use the analogy is like cell phones are convenient because you just click a button and stuff, but who actually remembers any of the phone numbers that are in here? So the convenience has actually made you a little bit more stupid. Not saying you're stupid. No one's stupid. Just one of those things where you have less of this equipment, and so some of the newer equipment, it's made it better for the patient, right? Less invasive. You only need like an A-line or a triple lumen, and a triple lumen. If you wanted, an SVR and an SVRI, but So you get some of that information, but from when I came from, you got to use the equipment and go, okay, I see all of these things. I'm gonna like wedge somebody. I'm gonna see. I have a continuous output one. I have a manual one. It doesn't matter. But this is what I know about the drug. This is what I'm seeing about the patient. And so I think that if I were to do this, or like go up on that, or turn that down, or I'm seeing this number do whatever it is I want or not want, I know that that drug does this. So I'm gonna do this. I'm gonna change it. I'm gonna go up or down. And I think this is what should happen. And it was like, there it is. It happened. Yeah. And like it stuck. You're like, I knew it, right? So it's like, it was an affirmation to you. And I just think like, because we don't get to use that equipment as much, you're just sort of looking at heart rates and blood pressures and kind of going by that, right? For the most part. And then you have flow tracks every now and then. And then we know like flow tracks can be wonky for a bazillion reasons. Basically, you have to have 4 stars line up in order for it to be effective and valuable. But then after that, it's like, when do you see a swan? Rarely. And when you do, you can't do anything with it, right? You just get to say it's still at 65 sticking out of their body. So when it comes to like the pressors, I understand why sometimes these things don't stick, because I don't feel like you use them, but maybe it's just not getting pounded into you the same way it was for me, right? So I feel like I benefited from using all of that equipment on a daily basis, or almost daily basis, because it did teach me something and I got to see live action. So you could apply some of this information to the flow track. But after it with the swan that's really there, it's like, I wouldn't even say it's helpful at this point, because you get to use it like once a year, right? But when everybody has it, maybe try to kind of revisit these concepts. So I'm going to do a hemo class on the 28th, and actually this our couple weeks from now, I'm going to put my information together for the class. But what I'll go over, because it's not like, okay, I'm not going to tell you much today because we're going to have a class then. No, let's talk about those things. So if we want to talk about the pressors, I always say like the kindergarten version of what all of them are is that if you go up on all of them, your blood pressure goes up. If you go down on them, your blood pressure goes down, or hopefully it stays the same if you're trying to wean, right? That's what they all do. But how they do it and what other things they can do change the game or change the nature of the beast. So the reason norepi is like most of the time used outside of like the neuro realm is because you're looking to squeeze the vessels, right? Or you're looking to help promote heart function. Phenylephrine doesn't do that. So when we go backwards and break down like what those receptors are that we're using to achieve these things, these effects, you're thinking of, beta 1 as being heart rate, right? And contractility. That's the thing I feel like over time, like especially with nursing school, and I always beat down nursing school because I feel like they try to do a good job, but then there's so many things that they just don't teach that I think should be taught. And not just because you're in critical care. I think that they're just things you should be taught, right? And I think that you get slammed into your brain, beta 1 is heart rate, right? It's that. I never heard anything about inotrope. I didn't know that was a thing. I thought it came from something else. I didn't know, And so I just kind of never understood that was something beyond just heart rate. So inotropy, contractility, is part of that beta reception, beta 1. And then when you look at like the vessel being squeezed, and that's peripherally, you're thinking alpha 1, right? So when you stimulate alpha 1, you're getting the tightness to the tube. So, there's 2 ways to increase blood pressure. I'm gonna go to my old style board. I can't do that white board thing on there. I keep trying. But, you have, let's say this is like the normal tube, right? Sorry if it's a glare, I'll try to do it this way. This is good, okay. So like this is the size of your vessel and it's completely filled. So then you might have vasodilatation, right? And when you have vasodilatation, the same amount of volume, if I put that circle and put it in there, it's not filling it all the way up anymore, right? It's the same amount of volume, but now you have a different size circle. So there's 2 ways to make the pressure that was in here be the same in there. Only 2 ways. I either have to put that volume in there and then add more, or I have to take the size of the tube and squeeze it down, right? It's either fill it up, squeeze it down. we tend to do both of them, right? We tend to flog your patients with a lot of fluid, and we add an oppressor that squeezes it down, right? So when it comes from like your low blood pressures, you're trying to squeeze peripherally so you can make the tube smaller and help divert blood and back to the core, and so that you can keep the core alive, which is the most important thing. But also we're trying to tank them up, as we keep saying over and over. We consider that CVP, if we talk about the notorious CVP that I hate, but your CVP of 8 to 12, and that's sort of like the textbook. That's not encompassing all of the other things that can make that thing look good and when it's really not, or whatever. But if you want to take textbook numbers, that 8 to 12 that we always consider as being like a normal CVP when you're in the ICU, not at home drinking your coffee like we are now, that means you have a lot of fluid inside that vessel. So you've tried to take the tube that was like this, that's like this, and turn it back into something like this and fill it right up, which is increasing your resistance. You need resistance in order to make a pressure, right? I need a force pushing back in on it in order to create pressure. So there's your blood pressure. I need some sort of resistance. But if you swing too far in the other direction, where all of a sudden I have way too much resistance, that heart is not going to be able to push very well against it. So maybe if your heart was okay and you had too much resistance, it's kind of like, I always use the analogy, like take your hand, right, and stick it, go into your unit and go in your patient's room and stick your hand on the wall, and now try to push the wall, okay? Probably going to exert a lot of energy and most likely not even budge the wall, unless also you're superhuman. Now go take your hand and go stick it on the curtain and push the curtain. The curtain's like a lot less SVR, right? But I am applying pressure. I'm making a pressure, right? It's just a simple way of kind of like thinking about how your heart is having to pump forward. So if you pump, if I'm the hand is the blood, I'm probably not going to move anything forward because I have too much SVR, which is that wall. If I take the wall and I decrease the SVR and I turn that SVR into something lower, now the heart is able to kind of push forward, and it's less effort, which means I'm probably going to get more blood out, and it's going to be a lot easier, which I'm not like having to use a lot of energy, oxygen, in order to push forward. So inotrope is helping to increase that force, so that as the heart's trying to push against pressure, the afterload, it's allowing it to be more effective, allowing for good blood flow. But when it pushes, it's trying to push forward, and it's doing a better job. So it's how I look at it is it's when you have somebody with a poor EF, ejection fraction, it's trying to improve that. It's trying to make it so that, and it's doing more than just that, right? But that's how I kind of look at it, is that, if your EF is 10% and I give you an inotrope, then I'm probably going to turn that 10 into like a 15 in my brain. That's how I think about it, because I'm helping it, I'm stimulating it in such a way that every contraction is going to be more forceful, so therefore it can overcome more resistance, and hopefully more blood will come out, so my cardiac output will improve. That would be like my stroke volume, right? So improving.
So the resistance you're talking about is the norepi clamping?
The alpha aspect.
The alpha aspect.
Yeah, so that's your afterload, right? So
yes.
I kind of I'm gonna try to draw this on the whiteboard on here. So I apologize if this is terrible. Let me do screen share, and then how do I do this? Boom. Whiteboard. Okay, let's see if this works. Can you see my whiteboard? Or is there white?
Yeah.
Okay. So this is kind of how I think of, I guess we're in green. Okay. This is going to say afterload, but I can't write it. This is going to go down. This is like your body. Should probably drew those in the middle. All right, this is really bad.
It looks cute.
Okay,
I'm not laughing.
This is like the body. This is just your legs only, but your body. And
so then, the double D's are the legs.
Yeah, those are feet.
Chuck, I should have known.
Okay, this is pre. So this is your. I'm just gonna write AF and then PR for preload, right? Coming back to the heart. So we think of heart rate. This is bad. Stroke volume.
No, honestly, it looks really good. I was just laughing because I looked up and
There are a pair of saggy boobs as feet. I got it. I got it. So, and then I talk about like the circle being filled versus the bigger circle. And you either fill, so increase volume and decrease God, this is terrible. Oh, Jesus. Okay, and then here we have and here we have okay. It's a weird thing. So I do this a lot, and I know I do this as like I go on, I start teaching, and I think of these concepts, and then in my head I do this like you can see what I'm looking at, right? But you can't clearly. It's in my brain. But this is kind of like how I think of it. I'm like, okay, so if I have a patient where I'm trying to get this one over here to turn into this smaller one, I'm using this receptor here. So by doing that, I increase the resistance, right? I'm also trying to pour in volume. So this is going to be where I, give you.
do you have the ability to change color now that we have like the diagram?
Oh, sure. Okay. Hold on. Oh, there's an eraser. Let me try this. All right, let's try that. Oh, no, it's. Wait. Why do I still have an eraser? No? How do I get the cursor back? Oh, there we go, I think. So, no. Oh, God. Oh, is it this? I think it's this. No, that's not it. Jesus, I don't know what I'm doing here.
All right, stick with the green.
I can't. I'm going to have to go undo. Okay. I don't know. I'm going to have to. I can't even get it back. Why does it keep doing that? I apologize. Oh, now I'm making. What is this? Is this just like a line? Ah! Oh God, I got it. Whew! All right, I'm not doing anything else. So this is going to be LRNS. So like, I'm just saying like here I'm giving you volume, right? So this is going to like increase my CVP. So while I'm doing that, so I'm trying to take this circle, and I'm trying to squeeze it down so it looks like it's this, right? But I'm probably not going to go from here to here, because then I'm back to being normal, right? What do I need a pressor for? If I'm going back to being normal, that's my body doing it. But I'm probably going to take this and I'm going to squeeze it down a little bit. I'm going to take that circle and maybe make it like, this big or something like that. Meanwhile, I'm dumping fluid into you, which is increasing my preload, right? By increasing my preload, that's supposed to be stroke volume, right? By stroke volume, and stroke volume times heart rate equals cardiac output, I kind of think of this in two ways. It's not just one thing, but...
So you squeeze the vessels that increase preload.
Yeah. It's kind of like these two. Like I think of this... Oops, shoot. Sorry. Undo. Okay, so what I'm thinking of is that the alpha turns this, or is trying to take this circle and squeeze it down into a smaller circle. Okay, by doing that, you're clamping on to that vessel. I mean, sorry, to that fluid, the blood, right? So that blood is the umbrella term for red blood cells and plasma, and you have fluid, right? I need some sort of a water content to push the red blood cells around. It's like their vessel, their transport vessel, their cars. So I'm trying to replenish the water aspect that's leaking if we're talking about sepsis, right? And that's leaving. So I want to squeeze this down onto. Oh gosh. Sorry, I don't. Someone's super loud. I don't know who. Sorry. So what I'm trying to do is take that vessel and squeeze it down onto the existing fluid, the blood. But then also what I'm trying to do is take and dump fluid into the intravascular space to replenish it. So I'm doing two things at once. I'm trying to squeeze it down and deliver volume so it has something to clamp down onto. Otherwise, you clamp down and you don't add any fluid. This is why I always tease people and say the first drug in sepsis is, and I'm usually looking for the word volume. And then the second one, volume. Third one, volume, right? In other words, give a lot of volume to really fill it up, to tank that vessel up. And then you're going to add in the pressor to sort of squeeze. That's the alpha aspect. So by giving you alpha, I'm trying to increase your afterload. I'm trying to make it so you have some resistance. Because if I go ask you now, if I said, we put your hand against a wall and try to push it, you took your hand and pushed it against a curtain, and you had something you felt, right? So there was a little bit of resistance with the curtain, not much, but you can see where I'm going with this. And then I say, take your hand and push it against the air. Well, there's no resistance to that air, right? That's like having like this giant vessel and no volume in it. So I need to squeeze it down and make some resistance, because if I make resistance, I improve your afterload and I increase your blood pressure, right? So by giving you squeeze here, I increase the resistance here to make a pressure. But also, as I do that, I divert blood back, so I'm improving your preload, which equals then your stroke volume. So I'm delivering more volume back to your heart. And I'm probably improving your CVP, but only because of diversion. But what do you sacrifice peripherally? Well, you sacrifice maybe some ischemia, because some of the smaller areas of the body, might be really lacking blood flow, and now you're kind of worsening that. That's why sometimes we see people who get really mottled areas, their pulses get really weak or absent, they get cold, extremities and stuff like that. It's because you're using an agent to sort of like push all the blood back to their core, which is what they actually need to survive, of course, right? It sucks if you lose a leg through this or a foot, but like that's the reality if you want to stay alive. So by diverting with the alpha, by diverting blood flow back to the heart, I'm increasing your stroke volume, but I'm improving your afterload, right? Increasing your afterload and improving your blood pressure, okay? So it's doing all of those things just sort of by itself. Then you have the beta stimulation, right? Which is improving the force. Those are like, those are beats, right? I'm improving that force so that when the heart has to beat forward, it's like you saying by yourself, I need to push this curtain, but you're struggling. So you call over me, and you and I both together kind of push it together simultaneously. So I'm improving that contractility, that beat, the force with the beat. So by doing that, I'm going to eject hopefully a little bit more blood out and improve my cardiac output. So I'm going to improve this. So two things are improving my cardiac output. Without the volume itself, right? Just by the drug itself, I'm diverting blood. I'm improving your preload and therefore improving your stroke volume, right? But so more stroke volume equals better cardiac output, because stroke volume times heart rate equals cardiac output. So that's going to improve your cardiac output. And then I'm also dumping in fluid. That's also improving your cardiac output, right? And then the beta stimulation, just from the drug alone, is improving cardiac output because it's improving the contractility with each beat, right? So alpha, diversion, blood going back, improving preload. Beta, improve contractility. So both of them are going to help maximize your cardiac output. And then also, you're dumping in all this fluid. So basically the take-home message about this drug in particular is that it supports not only like improving your blood pressure, but it improves your heart. It helps to improve how it's functioning. It's support to your heart, right? It is inotrope through beta. That's why it's really effective in patients, for the most part, especially in COVID, who are getting septic from, whatever their process is, if it's, COVID or something non-COVID, whatever. But that's how it's going to help be effective. The other drugs, they might do something similar, but maybe not all of it. So where phenylephrine is like not helpful in this is that all it's doing is this. This is the only place where alpha is working. So let's say I have a weak heart, right? I'm improving my afterload, but if I don't support somebody who has an EF of like 10, 15, 20%, 25%, these low numbers, I'm asking that this weak, it's like taking a 90-year-old man and asking him to push against your wall. Like I made your air, the first analogy where I just push you against air and like there's nothing, there's no resistance, and I turn you into a wall and ask the 90-year-old man to do that, it's probably not going to be effective. But if I give you an inotrope, I'm going to make that 90-year-old man feel like there's 100 90-year-old men pushing together, right? So it's going to be way more effective. Apologize for these 90-year-old men doing this, but my point is that you're just increasing resistance. So ultimately, that drug can actually decrease your cardiac output because maybe I divert more blood back to the heart because of this SVR, the squeeze. This is also, I probably should have written this before. This is how I think of SVR, right? But I'm not helping to support the heart itself. So even though more blood is coming back, it's still not able to push anything forward really effectively. So you're still not having any volume really come out of the heart. And it's probably going to get even worse because now all you've done is create resistance. You haven't helped it. You've just put more of a problem in front of it, right? It's trying to push against a wall, and you still left it a 90-year-old man. I don't know why I came up with this analogy, but this is what hit my head right now. Does that make sense, though? So where this drug can be beneficial, it has a great utility, right? So one of the things I would say about phenylephrine is that it's a little bit of drug and a lot of bit of volume. So what I mean by that is that, where you see it primarily used is in the OR. When somebody gets anesthesia because they're coming in from a knee replacement, they're not here for sepsis, right? They're just got a little hypotensive because of the anesthesia they gave. All I want to do is make your blood pressure go back up. I don't need all that other fancy stuff that comes with it. I just need to increase your afterload. That's it. I just need to squeeze back up what I just lost. And most of the time, we have to think, we work in the ICU, we usually use central lines, but that's not the general public. They're getting some peripherals. So if it extravasates, you're going to see that thing bubble up, and there's not going to be a lot of medicine in their arm or wherever that IV is located, right? So you're going to catch that probably very quickly, and you're not going to have to be as concerned with, necrosis of their arm and stuff like that. Not to say you don't think about that, but just generally the idea would be that a lot of stuff will infiltrate, or a lot of volume will infiltrate, and not a lot of drug will be there, and you'll notice it right away, or hopefully they should notice it right away. So that's a benefit in the OR. Where it's beneficial up where we work, SCU3, the upstairs SCU3, the neurocritical care group, they would benefit from this drug most of the time, right? The reason for that is that it only comes with afterload, increasing afterload, alpha, right? So most of the time, the patients, they have a stroke, they have a head injury, cracked their head. They're not here for sepsis. They're not here because they bled out, maybe in their brain a little bit, but they're not here for any of those reasons. And not to say they don't have prior issues where their heart is, I'm sorry, do you want me to leave this up, or, I won't get rid of it, but do you want me to pull back for a second? Or are you okay? With the view, I mean. You guys okay? Thumbs up? Good. But no answer, thank you. I'm gonna leave it just for now. You can see me, right? Okay, as long as you can see me. so what I was getting at is that in SKU 3, the neurocritical care group, it's not to say that you might have a 60, 80-year-old person fall and something tragic happen to their head, but usually what you're battling is the perfusion to their brain, not the rest of their body. But it doesn't mean that they don't have other underlying issues. Maybe they already have CHF, and that's a different story. But the majority of those patients, I would say, at least back in my day, we were trying to battle perfusion to their brain, and it wasn't that they had a lot of other problems. I mean, not to say they didn't, but they did. There are other things going on. But if you want to take the perfusion, so CPP. We're going to just suck up a half an hour just for me trying to draw this. Sorry, that was not supposed to be at times. I better just this is a minus symbol? Oh God. All right, MAP minus ICP equals CPP. Well, the thing that the neurocritical care group loves to do is not have high ICPs, right? And we know that 20 is sort of our cutoff to say, okay, we're safe under 20 and it's crap if it's above. And we always want to try to minimize the ICP. And we have all kinds of ways of doing it. Some are very, very non-invasive. It's like sitting somebody up at 45 degrees, turning off their lights, fixing their pain, anxiety if they're awake, putting them back down if they need to be sedated, whatever. If they have a fever, fix the fever. Just anything that, hopefully taste is not a part of this, but any of the senses, just stop stimulating them. And hopefully you can fix their ICP and it comes down. But then sometimes that's not the case. You have to do other things. And so, to do other things might be exhausting those therapies. So if I give mannitol a bunch, eventually my osmolarity of their bloodstream might get to be the point where, and I don't know what the cutoff for you guys is anymore. It used to be 320 was kind of pushing it. I don't know if 325 now, 320. So 320, after that you're okay, I can't give any more mannitol and their ICP is still this. Oh, okay, what's their sodium? Okay, have we maximized sodium? Their hypertonic therapy, hypertonic saline therapy. What other things can we do? Well, eventually you might exhaust that. So if you get pushed against the wall, so to say, this ICP, if I need a CPP is supposed to be 60, and you think of it just like your systemic MAP, right? So to know that you're perfused, all your organs, we consider 60. I know when it comes to pressors, we like 65. I think it's like a safety net if you ask me, but all my years, we used to do 60. Now it's 65. So we kind of try to push them up to 65, but we can safely say that 60 for an MAP is saying that systemically everything should be perfused. When it comes to the brain, the same number, just called cerebral perfusion pressure. And when it comes to CPP, we want 60. So that's easy to remember. It's the same number. Now, if I want to take the top of what is norm or allowed and say 20, then I need at least 80, right, to equal that number. So if I get to be 25, and this still always needs to be the golden 60, then what does that have to be? Right? Easy math. I can do this one, right? Easy math. But that falls under the MAP. Well, what is MAP? Well, it's your perfusion and it's how tight you are. And if all I want to do is drive up your MAP and your MAP is based on your blood pressure and all I want is a higher blood pressure, that's it. I just want a higher blood pressure to get you a higher MAP. That's it. I'm not looking, this isn't a problem about contractility and all this other stuff and sepsis and stunned myocardium and whatnot. This is literally my brain isn't being perfused adequately, so I just need higher pressure to force it up in there and you get better blood flow up there, right? And I have to overcome my ICP. That's the only way I can do this. So if I can't fix my ICP anymore, all I really need to do is drive up my MAP. I don't need a faster heart rate or, you know, like I said, contractility, which comes with your Levophed as just that one drug alone, right? We didn't say epi or at least dopamine, but just pointing that out is that what is the nice difference between just these two agents that you might see more commonly than anything else outside of vasopressin. You know, we usually don't whip out any dopamine, and it's not very often we'll whip out epinephrine either. Usually it's after a code or now they're on their fourth pressor because they're dying from whatever the sepsis that's killing them is. But usually it's kind of like one of these two things that we see more than not, right? And so in most of the world, we're looking for something that supports inotropy. But in this scenario, or most of these scenarios for the head patients, and again, maybe they have a poor EF because they're 85 and then had their stroke. So maybe we do have to consider some inotrope support. So maybe that is where Levophed would be a better pick over phenylephrine, but also driving up their MAP to overcome their ICP to equal a better CPP. But if not, and it's just sort of like healthy patient otherwise had just a tragic event, then maybe all I need to do is drive up their afterload to improve their MAP by increasing their blood pressure. But that drug for other patients can equal a lower cardiac output, because if all you do is tighten that vessel and cause so much more resistance and the heart can't overcome it, then you're going to decrease your cardiac output. You're going to lose your blood pressure because their heart can't. It's like you're not helping the heart. But those are weak hearts, you know? Those are patients who are having a weak event. Maybe they had an MI, maybe they have stem myocardium from sepsis, or maybe they came in with already either systolic or diastolic heart failure, you know, some sort of CHF. And that might be underlying already, you know, it's not what's brought them here. Maybe they just happened to like fall on the ice skating, and then they had all these other problems, but here they are with a head bleed. Are they here for sepsis? No. Are they here for hemorrhagic what am I trying to say? Shock? No. Maybe consider it to their brain, but that's not worth considering like global hemorrhagic shock. So this would be, you know, an issue with just some blood in their head, and now they have ICP problems, and all I need to do is maybe just increase their afterload, their MAP. But if they have all these other problems, pre-existing problems, then maybe phenylephrine won't be the right choice for them, because we do need to consider supporting their heart too. You know, and maybe sometimes we don't know. Again, medicine is often trial and error. You know, we say this is what we think should happen, and then we throw the drip up, and then bad things happen. You know, maybe their blood pressure crashes, and you know they look worse for X, Y, and Z, and then so we consider thinking, oh, okay, maybe they do need inotropic support. Let's do some Levophed. You know, the thing about, you know, the head is that, you know, I don't need your heart to beat faster to support it, right? So that's why I don't need beta stimulation. But one of the things you get through inotropic support through those agents is maybe a bit of a faster heart rate, right? But that's not necessarily what I'm looking for. That just might be an adverse effect that you get from that drug. So in other words, if they do need Levophed because, yes, their CPP is low, but you know, phenylephrine is not going to be the thing that helps them because they need inotropic support, I might get an elevated heart rate because I get beta stimulation through this drug, which is Levophed, but I do get that little bit of a faster heart rate, maybe that I'm not looking for. That's all. Does that make sense? I mean, these are just two agents, and I can keep talking about the other ones. I just pointing some of this out. So when I think about how these drugs work and where they're working and like what you're doing, I think of like this kind of a diagram in my head, and I'm thinking like, oh, you know, by giving them this, I should fill up the pipes better, which means more blood will go back to my heart, which is this preload, right? Which means I'll increase my stroke volume, which means my heart rate probably can come down. That's another thing with sepsis, right? They're very, very vasodilated. They're losing fluid, water, third spacing. And so their heart rate usually shoots up to compensate for their cardiac output, to achieve the same cardiac output. So I know that if a septic patient, I dump fluid in and improve this CVP, I'm ultimately improving the stroke volume, which means I probably see a drop in my heart rate because I'm improving the stroke volume, so therefore I'm improving my cardiac output. So this doesn't have to compensate as much. And we talked about before the curve, right? Remember this? We don't know where this is for every individual patient, and this is a x-axis, y-axis, and you can use them interchangeably. You can call this, you know, their cardiac output and their heart rate, or you can reverse it. So if you can't remember this, you know, the aspects, but you just don't remember which one went where, interchange them. They literally show you the same thing. Basically, as my heart rate goes higher, right, my cardiac output improves. But eventually, if my heart rate's too high, I actually go down the curve, right? My cardiac output actually gets worse because I don't have time to fill. So by giving them more and more volume, you know, eventually if you don't have a lot of volume in sepsis and your heart rate is too high, and you give something like Levophed and it's beta agonist, you're only going to make their heart rate go higher. So you're going to probably, you know, maybe their heart rate was right about here and their cardiac output was just good enough, and then now you're Levophed and you haven't given them an ounce of fluid, so now they're actually going to get worse, right? So by giving them more and more volume, I improve their stroke volume. By improving their stroke volume, I improve their heart rate, and by improving their heart rate, their cardiac output should stay the same or even get better. But I've also brought you probably back down a little bit, right? And then I go and give you something like Levophed, and maybe I brought you back up, but I'm still on this side of that line, or at the top of that line, but I haven't pushed you over the line. So that's why I always laugh and say, hey, what's the first drug of choice in sepsis? Volume. What's the next drug? Volume. What's the volume? Third, right? Lots and lots of volume. These guys need to look like Michelin men, or you're not doing your job right. And then later we'll diurese it off, you know? It's like we can't figure out what we want to do. A lot of volume now, no volume later, right? So that's just like Levo, that, or norepinephrine, and that is phenylephrine. That's like two of the things that I like to talk about with those particular drugs. If you took dopamine or epinephrine, everything I just drew up there is exactly the same. It's just how they work is a little different. Meaning, like with epinephrine, you know, you get a lot of this one right here. You get all of the same things that norepi gave you, except you get a lot of this one, right? So this is why in a code we go, give me an amp of epi. No one's going, give me an amp of norepi, because you don't get that big bang for your buck, that inotropy, that big, you know, this is why their heart rate shoot up to 200 or 250 or 8 million, who knows. But they get good squeeze, they get real good alpha. We're trying to divert blood flow back to the heart. We're trying to rev it up, get it beating, shoot out some blood on the other side, which is that cardiac output over here, and really squeeze them and improve their afterload, and hopefully get blood circulating, right? And rapid heart rate. But again, we probably put them over here at like 220, right? So as it starts to wear off, you know, they're kind of trending back up, and hopefully with, you know, all the fluid and the improved SVR and then diversion of blood, we get their cardiac output hopefully up, and then their heart rate is sustained, and then they're somewhere up here, hopefully, or maybe on this side of the curve, but somewhere up here. But you get a lot of beta. That's the difference between norepi and epi. You get a lot of beta, but you get a lot of inotrope too. So it's like so much better of an inotrope than norepi. But what is the consequence? Well, probably way too much heart rate that you're not looking for. What did we say about sepsis? I've already had you compensate here. I've given you fluid, hopefully brought you over here, and then I go and give you epi, and I probably drove you over here. So probably not the greatest choice. Where norepi supports the heart, right? I get just a little bit of the increased heart rate, hopefully. Some people are sensitive, I will say. Some people, you know, you increase the norepi and maybe their heart rate doesn't change too much. I've also seen people on really like small doses that have just a lot of tachycardia. Maybe their heart's just super irritable, you know, maybe they have underlying AFib and you just keep sending them back into it because of how it's working. But generally speaking, you don't get like the crazy heart rate associated with norepi as you do epi. So you're hopefully maintaining the patient somewhere up here with their cardiac output based on where their heart rate is, you know. Dopamine, it's unique in itself. It works the same as all of these. It has the same beta and alpha, right? But it's unique on what is the prominent receptor it's working on at what dose it's being given. So dopamine, I think textbook is 1 to 3 mics per kilo is you do 1 to 3 That is a 3. 3 to 10, and then 10 to 20. That is a 2. I swear to God, that's a 2. So 1 to 3 is considered more of this beta stimulation and not really much alpha. Like really not alpha at all, but maybe a smidge, a little smidge. Right? Because I don't think you can have this drug go into your body and your body's like, oh, it's that 3, and then you go to like 3.1, and all of a sudden it's like, nah, we will bring in the alpha. No. I think it's just the predominant effect you see is really just beta. And I'll try to just do one more quick drawing. So that's beta. That is a B, or with a line. This is predominantly now both. So this is beta and alpha, and we're talking about beta 1 and alpha 1, and then this is predominantly more of just the alpha effect. So beta, alpha, and then more alpha. So again, the utility is the same when it comes to where those receptors, like how they're working, right? So if I go to 8 on my dopamine, I should be doing what norepi and epi were doing, right? I'm still helping with inotropy because it's beta. I'm still helping with afterload because it's alpha, right? It's doing those same things. But what is its issue? Well, it's proarrhythmic dopamine. You see people shooting out PVCs left and right, so that's one of its downfalls. And you see, like, if I really want this effect, but I don't need a lot of it, I might lose that other effect I was looking for. So in other words, if I really was looking for alpha, but your like blood pressure is good, and then I get you down to 3 mics, and then all of a sudden I'm just more of a beta, and I lose some of that alpha, I might not be able to wean you so well because we were still looking for some of that alpha effect, and now you're not really getting it because you're just getting more of that beta effect because I've weaned you from that 3 to 10 zone now down to like 3. So where norepi is better is because it's like this uniformed stimulation of both of them, right? All the way through, whether you're a 0.02 to 1. You've got beta and you get alpha. Does that make sense? So this, it's like, what effect are you looking for? And it's like, well, if I need the alpha, I gotta at least get you to about 3 in order to really, or 3.1, I guess. Somehow your body knows, but. By the way, old school used to teach this as renal protective. It is not dopamine meaning. This is not renal protective at low doses. All you're doing is really just increasing their heart rate, which means cardiac output, heart rate, stroke volume. Directly. Now, I could argue why it would be okay still to say that kind of. It's one of those things where like better cardiac output equals better perfusion. So I think that's actually kind of a true statement, but not directly inside the kidney, like when we consider vasopressin and then the V2 receptor causing like the artery to dilate, accepting more blood in. So that's what's unique about dopamine. A question was asked, and I've thought about this for years too when we used to use it. When someone's on dopamine, do they feel good? Like, do they seem like they're better? Like, I go, no. No. They're usually dying, for one. And 2, even if they were able to, like, kind of communicate or whatever, I don't think I've ever come across a patient that was like, yeah, I feel so good on this. And as I'm weaning it off, they're like, I don't feel as good. I'd be like, no, I'm not sure I've ever seen that, so.
So which patients would you usually be using dopamine with? Like, I understand you need the heart rate, not the blood pressure as much, but like, what patient population is that?
So, good question. So the first population that jumps out of my head almost right away is a patient who's dead. And I have a code card nearby, and they're either bradycardic and with symptomatic, or they're asystolic. And I'm giving these amps of something, and maybe we get them back, but then they kind of go away again. So what you have ready to go, foil package, tear it open, hang it up, and let it drip into them is dopamine. So you get beta, alpha, obviously different ranges, different kind of like effect, but you got it. It's right there, and hopefully that keeps them alive. And if they're bradycardic and all I'm looking for is to speed them up, that's where dopamine also can be helpful. Now, you do have in the top drawer these little vials of all kinds of things outside of just your amps of this, that, and the other thing. Then you have two Norepis. The two Norepis, they're each 4 milligram vials. And if you remember what is your basic concentration bag, we always have 8 and 250. And so there's a 250 bag kind of in the very bottom of saline. You just tear it open, take out those 2 vials, draw it up, and now you've just created your homemade 8 and 250, right? But that takes time. So if you need something right now and they're dead, dopamine, way to go.
So would you really ever have like a patient on a drip of dopamine at 2 for like days and days, or is that not really a thing?
Not really a thing anymore.
No.
Now here's the thing: is in our environment, pretty much across the board, whether you're downstairs in COVID or up here, unless there's something with COVID that I don't know about, the answer would be no. I do know that they use dopamine a little bit more up in CICU, but I don't know the reason. There's got to be like certain things that are happening with the heart that maybe this is just the better agent. Maybe it's a long time ago. And again, we have Norepi now, and we've kind of, it's so much more in vogue. It's better. For years and years we used to steer away from it, and people have heard leave a fed, leave them dead. But obviously it's the first drug that we use now, or one of the first. But what you might have seen before was the synergistic approach when we thought the patient needed an inotrope, you would see dopamine and dobutamine together. Now, up in CICU, where they do a lot of different like MIs and stuff, I can't speak to the fact that maybe there might be something that's beneficial with dopamine to help take care of those types of patients, whatever those patients might be. I don't know. That'd be a good question to say to maybe one of like the CNEs up there. Be like, hey, do you guys use dopamine a lot? Or if you don't, what type of patient population do you guys tend to use it in? Because we don't. And I gotta say the reason why you might see it is that the patient coded, they had it, it's up. They also added in Norepi, they also added in vasopressin, and it just happens to still be on because even max doses of the other two things, and they're still hypotensive, so therefore the dopamine's still running just because that's what they started with. Or maybe that wasn't what they started with. Maybe they had vaso and Norepi, and then the patient coded, and they threw up the dopamine because it was there, and just whatever. But I would say usually you're not going to be walking into a patient that has any dopamine running for a specific reason that I can think of with our population. But,
I just wanted to make sure I wasn't missing something like huge there.
No, but it's what's beneficial about it is that this is me just saying what I'm thinking. This isn't me knowing these things exactly, but I think it's because it's stable. It can stay in suspension or in its bag longer, where other things sort of like have a very short I would say half-life, but shelf life is what I'm trying to say, shelf life. So that, you don't see a bag of Epi just like hanging out, right? It's always refrigerated and it has an expiration, where dopamine is in this pre-made foil package. So apparently, it can stay in the code card for, I don't know, days, months. I don't know the longevity of it. But it does the things that we want it to do. It speeds up your heart and it causes constriction. So it helps with blood pressure and the speed and contractility of your heart, right? And then maybe you use it to start to help somebody, and then you stabilize them, and then you try to switch them off of this drug to the other ones, the ones that we're more used to using. So, maybe you throw up some vasopressin, and then you add in the Norepi, and as you up titrate your Norepi, you down titrate your dopamine to sort of like exchange them to get them off, and then you have just your vaso Norepi that you're used to using. And one thing that I just historically have seen so many times is that dopamine is very pro-arrhythmic. So I used to see tons and tons of PVCs, and that's with normal electrolytes. It's irritating, I guess, to the myocardium. So you would see a lot of PVCs being thrown. And sometimes I would see, I think I could be making this up, but I felt like when we used to use dopamine, I think I saw more AFib-induced like pressors with dopamine than I ever have with norepinephrine, like not as irritating or irritable to the heart. I could be making that up, but if my mind serves me well, I feel like I haven't run into as much AFib that we think is secondary to your pressor, as I have with norepi. So a lot of dopamine. Dopamine did that a lot.
Okay, all right.
And then, so that you have your dopamine, you have your epi and your norepi, you have your phenylephrine. And the outcome, right, is always this, right? This is what you get in all of them, is a better blood pressure. Hopefully. Right? But they all do different things, right? Some work here, or some just work here, some work here and here, so they support each other. And then you have the infamous vasopressin or vasopressin, right? So, what does that vasopressin do? How is it working? Well, it actually doesn't work on those receptors. It works differently. It's working in your kidneys, right? So it's working on your RAS system. It's antidiuretic, right? So ADH, antidiuretic. And does anybody remember or want to give their best shot on what they remember about that, or if you know anything about that?
All I know is that it's antidiuretic. But so tell me this: I walked in and my patient was on only vaso. That was the only pressor.
Yep.
And we were like hardcore diuresing this patient, and I didn't understand. And so, is there more to it, or was that just like a mistake? Because I don't get it.
I know, right? It seems weird that you would add ADH and they'd pee better. It's like,
Is it just because now they're having better pressure?
Yeah, I mean, there's that.
Well,
there's
it just seems so
counterintuitive. Yeah.
Yes. Like, why wouldn't we just use something else?
Yeah. So, vasopressin, it ADH, right? So it's beneficial for more than just low blood pressure. And what makes it different than, if anybody's heard of desmopressin, vasopressin, is that structurally, vasopressin, however it is chemically structured, some sort of, I think, like amino acid or whatever, I don't know, is it also causes vasoconstriction, but not where everything else does. Typically, a big chunk of where it works is in the splanchnic bed, which is kind of like your intestines, your mesentery, near your spleen, your liver, like this area of blood vessels. And so by causing vasoconstriction there, you do where it would do anything else. It diverts blood, it pushes it back, right? But you run the risk of having the infarcts or ischemia to that area. So if someone had bowel surgery or has a clot already existing, that I might say, hey, to the team, like if they were about to order, I might say, hey, are we considering that this may not be the best drug for them? Yes, you'll get blood pressure, but do you run the risk of causing a worsening ischemia to this or to the anastomosis or something? It's food for thought, It's always one of those things just to kind of raise. But it's working in the V2 receptor, so the V2 receptor is causing the retention of water, and you also get, I think, a reuptake of your sodium. So then you get intravascular water sort of going up, right? Because you're not allowing it to go out, and so you reabsorb water. But when you reabsorb the water, your intravascular volume goes up, therefore your preload should eventually start rising, therefore your stroke volume, therefore your cardiac output, and then ultimately why you're improving is that you have higher intravascular volume, and therefore if you get more volume to your kidneys and your kidneys see a higher flow, then they're going to make better urine because 20% of your cardiac output goes to your kidneys. So if it sees that, it's going to allow for better urine production. But that's if there's water to be held on to, right? So this is where you flog them with fluid and you're hopefully holding on to that intravascular volume and not allowing the stuff that wants to leave to go out. And then, you do have to worry about, sodium levels going up. So it's like an interesting drug because it doesn't work like just in one area, and you guys would be better to answer this question than me, but a long time ago when like neuro still used to be throughout, and maybe even for years after neuro was in 3, but we used to never want to use vasopressin unless we were like sort of pushed up against a wall for head patients, because I think we didn't know, and I say we, like, you know, whoever studies vasopressin didn't really know if vasopressin caused cerebral arteries to sort of to kind of clamp down, and then you worried about promoting ischemia or poor perfusion to the brain based on this drug that you're trying to cause the systemic blood pressure to go up, but wasn't sure if you were actually doing any harm up here. So I felt like the only time we ever whipped it out for neuro patients was when we were sort of like last resort, trying to figure out if, you know, trying to save the rest of their body, which ultimately saved their head, right, perfusion-wise. Now, we use that for DI, right, and that's where I was going to talk about desmopressin. But this drug itself causes blood pressures to go up because it increases SVR, where desmopressin doesn't do that. So people who have, you know, issues with clotting from like a von Willebrand or a hemophiliac or something like that, they might be sniffing that, or maybe they have just actually a born central DI where they just can't hold on to water. So why are they using the desmopressin? Because it can be used for some of these other processes that isn't a water issue, like retaining water, but maybe they have it for, like I said, like some sort of a clotting disorder. Then, you know, they're sniffing it. This is like I believe they have a couple of methods that they can deliver it, and one of them is a nasal spray. And so you might see them, like, I say you, someone out in the world, in the public, might be like huffing some DDAVP, which is desmopressin, and using it to help with either their water retention or you know, clotting disorder, but they're not having these like spikes in their blood pressure associated with it, because it doesn't work like that. So that kind of separates those two, to my best knowledge. There's probably a bunch of other things, but so vaso, you know, why you might see somebody pee is because ultimately you might improve their cardiac output by diversion and water retention, and then increasing their cardiac output, and therefore better flow to their kidneys means hopefully better filtration, and then water might come out. So you have better filtration because you're actually getting blood flow to their kidney, and then the increase in just the overall water in their body. So once you see more water, then the body's going to say, okay, now I can actually allow some of this to leave. Now, interesting enough, if you have a patient that's on it, and usually you're used to seeing the patients pee because they actually have a good blood pressure, and they actually start not to pee, you might have one of these little patients that love to not follow the rules, and they actually have retention because of the vasopressin, and their blood pressure is okay. So one of those patients, you might try to wean that off, and let's say their blood pressure won't tolerate it, so you swap out and give them the Levophed back, right? So either down titrate or just shut off the vasopressin, and now they're just on their Levophed for really the alpha, the blood pressure. They might actually start peeing better because now they don't have the ADH going on in their system, or as much. But that's not typical, but I will say, you once in a while you're like, this doesn't make sense. This patient was peeing really well, and now all they're on is just their vasopressin, and they don't pee really well. And you're like, wait a second, this doesn't make sense. Are they that one person out of the handful that I take care of? So just something to think about. It is, they are interesting drugs. So Ashley, does that help kind of circle back to, like, I mean, it's one of those things where hearing it over, thinking about over, and then what I mentioned in the beginning of this conversation was the equipment that you get to use, right? So if you were able to use equipment that showed you a lot of these numbers, that those things can change, sometimes it solidifies it, cements it in your brain just that much better than just hearing the theory and trying to remember it and just pull it out. I think when you see something live action in front of your face based on what you think you know, and then there it is, it puts it into you so much better, I think. So, you know, we don't take care of swans all the time, so you don't get to see that. But what you could do is apply this information to your flow track. And I think we went over this one time before. Do you guys want to talk about a little bit of that, just to reference these drugs? And into, yeah, okay, I see I see a yes down there. So your flow track. I'm gonna leave this up actually because I might point to this diagram. But what you have 7 numbers that we're used to seeing, and I always say I don't talk about a couple of them because I don't use the certain indice numbers to think about the patient. I think about one indice number. The rest of them are just like their normal number. And what I mean by that is like you have your cardiac output and then you have a cardiac index. I think about the index. When you have your SVR, I think about your SVR. I just don't think about your SVRI. When you have your stroke volume, I think about the specific SV. I don't think about SVI. And then you have your SVV. So in order to calculate the SVR, so let me back up, hold on, and say to have a flow track, all I need is an A-line. I don't need anything else. But in order to get your SVR, and then therefore your SVRI, I need a CVP to calculate that equation. And if I don't have a device that tells me what my CVP is, it's just that little bit of information I won't be able to obtain. So to use a flow track, I do only just need an A-line. It's just if you need that little bit extra information, I need like a triple lumen. I mean, I need some sort of essential device, and we say PICC lines suck, and they do, but if that's all you had and you want to trend the number, by all means, you could throw it up and just know, like, this is probably not the most accurate information, but at least I can trend it, and I know, like, maybe if the patient is in this number, they look this good when it falls down below that number, even though those numbers don't make any sense, at least I can trend it and say, okay, clinically, this number, this is what they look like, clinically, this is the number, this is what they look like, right? But in order to get like your SVR, I need your CVP. So it's your MAP minus CVP divided by cardiac output times 80. That's SVR. And so, do you need me to say that again? So MAP minus CVP all over cardiac output and then times 80. That is your SVR. So that's why if you have a flow track with no CVP, I don't get a SVR. Or let's say you have a CVP, but you're giving a med through it, you'll see that that machine honks at you because it's like, hey, I don't have a CVP. I can't tell you information. And you're like, yeah, I get it. I'm giving like vancomycin through it, so shut up, right? So one of those types of things, but you need that information. So if you're looking for it, great. If not, then the other stuff you can get. So when you talk about your cardiac output, what do all of these drugs for the most part do? They improve it, right? Except for phenylephrine, who's a jerk sometimes, can really mess things up for you, right? Because if all I do is increase just your afterload and I don't help with forward flow inotropy and contractility, right? I don't help with that pump forward, then I'm probably actually going to worsen my cardiac output. I might not do it. Like if you take a person who's 40 years old with no health history, and like I said, they're just having a knee surgery, you throw some phenylephrine up, that's fine. That's not going to ruin it. It's just knowing that that's what this can do. So if you see somebody's cardiac output, this is why I say if you had a SWAN, but in this case you have a flow track and you see patient's blood pressure drop, and then you have your machine and you see cardiac output and you hang phenylephrine as your drug and you see your cardiac output fall, you're like, aha, this might be that patient, right? That has not a great heart and we need to support it. So we need beta, right? We need something beta to help them. So, but all of them will help increase my CO, my cardiac output. Now, CO is liters per minute, right? But when we think about the liters per minute, are those liters per minute adequate for what's happening in their body right now? So you sitting here talking to me and me boring you is like 4 liters, right? Ish, give or take, right? Depends how big you are and what's going on with your body. But if you're sick and I'm vasodilated or I have blood loss, which is like whatever, all of these other problems, I might need 9 liters to do exactly the same job. So that's your index. That's like your same liters per minute, and also taking account your meters squared. So this is taking your body surface. So if you're sitting down and not doing much and not exerting yourself, 4 liters might cover every inch of your body. But then if I get super sick, I might need 10 liters to still do the same job and cover every single inch of my body to push enough blood flow to get there. So you have to consider, you need a cardiac output to give you a cardiac index, but cardiac index is so important because it's telling you if you're really perfusing the body. Because 5 liters is great. Go look at a book. 5 liters is great. The patient might be dying with 5 liters. They might need 11 liters to keep them alive, right? So that's the idea, is the index. Is my index okay? So if my index is, I think we say textbook is 2.5, but usually, I say usually, a lot of the times I find that patients were hard to maybe get there, at least initially. So at least clap your hands if you got them above 2. Like if everything you could do and you got them above 2, you're happy. So you would strive to really increase them above 2. 2.5 would be great. But if you saw them in the ones, 1.8 or something like that, you're always like, all right, we got to get them higher. So that's where index is super important. This SVR, I don't look at it like an indexed number, which is what you see with some of the information from obviously the flow track and then some of the SWAN information. But how I got taught and how I think about it and also how I teach it is I know it has an importance, right? But that's not how I think as a nurse, at least right now. How I think of the SVR is literally like a gold standard number, saying like 800 to 1200 is your SVR. So if I'm below that, I'm probably under-resuscitated and dilated, usually a combination of the both when we talk about sepsis. Or if I'm really, really high above the 1200, I'm way too tight. So I either have too much fluid or I'm already maybe clamped down too hard. Maybe I have like too much pressure or whatever the problem is, but I have too much resistance. So that kind of like sweet spot of resistance would be that 8 to 1200. And
in that situation, would you like diaries, come down on your pressors, stuff like that?
It's you can't answer it just like that because it depends on what's going on with the patient, right? So if you were telling me, if the answer to that would be if you are going up and up on your pressors and all of a sudden you overshot and your blood pressure shot way up but they're still dealing with their sepsis, then no, it would be going down on your pressors and not diuresing, because you're probably going to kill them if you diurese them. Or is it something like they just need a little bit of afterload reduction with their squeeze, which seems sort of counterintuitive, but sometimes it's really inotrope. It's more not so much the squeeze is like the pump forward. So if someone was showing signs that at 14 or let's say 1300, and if you drop back their Levofen, their blood pressure just tanked too much, but you get them up a little bit and their blood pressure was good, but then their SVR looked too much, and they were showing you these signs that they were in pump failure, then I don't want to change their squeeze so much as I want to like really, really maximize their pump. And so I want to help try to overcome their pump with cardiac output. But what you do through beta agonism is you also afterload reduce with something like dobutamine. I'm really trying to get, their 1300 maybe to turn back into 1200 with dobutamine, but also really nail each beat with like a really good force. Try to really overcome and push blood forward. So diuresis wouldn't be the right choice there. But then, maybe down the road they're getting better and their pump is not great, but they're off their pressors. So yes, maybe something like diuresis at that point would totally be the right choice. So you can't answer it, I don't think, with yes or no. It's kind of, again, with most things, most of the answers to a lot of the questions it's with what's in front of you. But here's hearing all these different options with then applying it to what makes sense in front of you, right? So you see this patient that you're going up on your pressors, probably diuresis is not the right choice right now, But then let's add in a twist to that. What if you have profound ARDS and your PF ratio is like 10? Maybe diuresis would be okay there. But then what do you jeopardize after that? Renal failure, ischemia to an appendage, I don't know, all of the above. It's never so, black and white in those instances. So cardiac output, so SVR, talk about cardiac output index, SVR. The SVRI is like taking your SVR but applying it to their body surface area, which is not the way I think. Because I think about what is the tube and how tight is it. That's all I'm thinking about, right? That's where the SVR in my brain comes in. So I don't really know how to speak to the SVRI other than telling you it's an index number. And then when we talk about stroke volume, I'm talking about how many cc's is going out. But when you talk about the SVI, you're talking about, is that enough ultimately for their body? But that's then saying, what is my cardiac index? So are the liters enough, which means is my cardiac index appropriate? So SV is really just how many cc's with each beat fly out. So, obviously if I have a patient who's, 50 kilos and I have a patient who's 100 kilos, the same 70 cc's might not be appropriate for one, but might totally be appropriate for the other, right? 70 is normal, but the indexed value would be not appropriate based on their size and what's going on. That's where I just see constantly just keep falling back to what is my cardiac index. I want to know if the cc's are appropriate, but I also really just want to know the cc's then equal the cardiac output, which then equal the cardiac index. So to me, I just keep falling right back to, is my index okay? How do I maximize it? But when you look at the stroke volume, which are the cc's, are they okay? Like if you have 30 and I need 70, maybe it's volume. And then the question is how do I get the volume? Is it actual volume? Is it diversion? Is meaning like if I clamp you down harder, do I send more blood back, which means you'll get more cc's, but it's only because I clamped you and moved blood from here to there, right? Versus actually instilling you with another liter of saline or LR or something like that, if that makes any sense. So that would be your stroke volume. And then the one that I don't think it's really that hard. It's just, I think it can be confusing at first, especially when you're sort of like hearing it for the first few times and trying to get it in your head. Like, how does this work? Is your stroke volume variability, or SVV. That's the number we're using this machine to say, oh, how much volume? Do you need more volume? So the saying is high is dry. So it's a value based on percent. So when you see the number, it's a percent. Right? So when you see 7 is 7%. If it's 25, it's 25%. How I look at it is if you take what I'm going to try is 2 circles that are the same size. Okay. And I fill this one halfway up. Okay, that's full. And this one's all, oh God, Jesus, Mary and Joseph. Okay, this is all full, believe it. Trust me, that's a full vessel. I don't lie. So I always think of like a garden hose analogy, right? So if you were to like turn the knob on 2 identical garden hoses and you turn one just sort of like a little bit so water's kind of trickling out the other side, water's coming through, except if you were to step on the hose, which is sort of this one to the left, it's squishy. Because it's not completely full, right? There's blood in it, or in this case water, because we're talking about garden hose. But if I were to step on it, it's going to squish, right? So when I squish it down, that's an arrow pointing down, okay, in there. So that space that's vacant, if I were to step on it, the arrow pointing down means that it's going to get squished all the way down to the fluid line, and that's it, right? It's going to go blah, 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 blah. Right?
And what would that SVV number be? Would that be like...
wait, you're getting ahead. I'm going to get there. I'm going to give you that. Okay? You zip it. Kidding. Oh, I'm actually getting to that answer. So you take this garden hose and you crank that baby right up and it's like flying out the other side. So clearly, if I were to step on this, it's going to be really tough, right? It's not going to squish that much. So if I take those 2 and compare them, the one that's having water spit out, or this one on the right, that's filled. It's adequately resuscitated. It's got volume all the way around in it, right? So if I were to try to compress, and this is where the venous system, you have to think arteries, veins, the arterial side, high pressure system, the venous side, lower pressure system. So when I have positive pressure, and this is the key, you have to have positive pressure for this to work. And I always go spouting off, and I'll do it again. You can get numbers no matter what. Intubated, not intubated, any rhythm, they could be dead, and you'll get numbers. They just won't mean anything. So if you have all the stars align, which I'll say in a second, but one of them has to be positive pressure. That's like my foot squishing down on the garden hose over here, right? So if my foot, aka the breath in, the positive pressure, squishes down on the one that's full, there's not going to be a lot of variation inside that vessel, right? If I go to the one on the left and I go and step on it or put my breath in, there's going to be way more variation, right? This fake arrow I drew right in here, this space, a lot of variation. So high is dry. So that means if I'm over and their gold standard is 13, so past 13% is considered dry. But I want to step back and say that's one number saying that. That's not the clinical picture. So there's many times where that number will say, 50 and they're peeing great. And it's like, no, if you treated that one number, you'd just be doing the patient a disservice, right? Just like anything I've ever said. I sometimes there might be this one time where one number bugs you and you just can't put your finger on it, but you really shouldn't be treating a patient just because one number said something. You got to take the whole picture. But if you were to say all the stars are aligning, what past 13% variation means is that they're dry, they're intervascularly dry, and that you need to just go put some more fluid in there. So that's another liter of LR or something like that. So 13, higher than 13%. Do you see the analogy though? It's the reason why positive pressure is you got to push on the vessel, not like go away from it. That's why the idea is that you have to be in a sinus rhythm. You have to have the regularity. So even if you're sinus, but you're having a ton of ectopy, that's not going to be regular. So that will throw the numbers off. You'll still get numbers, they just won't be accurate. So the perfect world would be you have to have a working A line. I want a raise of hands. Who has ever had a working A line? Nobody? Got it, right? Because they all crap out, right? But you have to have this working, non-positional, crazy A line. A-line, okay?
Mark, I actually had a working A-line and I thought of you.
Did you take a picture of it?
I almost did, and it works for some great gifts, and I was like, holy shit, it actually works, and I don't have to manipulate this poor hand into like a morphed
Yep.
polar like right angle to get it to work, or I don't have to pull back on it.
Yep.
And I don't have to re-zero it 1,000 times. It was just perfect. And I thought of you being like, wow, it's the first A-line.
You're like, get me a flow track stat. But then you're like, oh, they're in AFib. Shit. So never mind.
I had to say that.
No, that's great.
I thought of you when I saw that and laughed.
Yeah, because you have to have it. Well, first off, you have to have the device that gives you the information. So that's your A line, and then it has to be like working, right?
Yeah.
So that's one piece, and then you need to be in a regular rhythm, so sinus rhythm. Then with the sinus rhythm, they suggest that if your heart rate is greater, so let's say it is sinus, no ectopy, but you are greater than 120, then the information starts to kind of like not be as accurate. So under 120, sinus rhythm, working A line, and positive pressure. So again, if you had AFib on their monitor and they were extubated, you will see numbers in every square. They just won't mean much. That's all. There'll be information because, and this is, I can't speak to this, all right? Some sort of physicist can tell you this information, but there's whoever invented the information, that little brick is the brain that sits below the monitor, the iPad looking thing. And that is doing these like crazy calculations and algorithms based on pulsatile pressures and all this stuff. And so what it's looking at is that with the variation in your respiratory rate or respiratory pattern into that vessel and changing the vessel, like the dynamic in there, if there's a lot of change, that means you're dry. If you don't have too much change, that means you're probably adequately hydrated, intravascularly repleted. And therefore, the information, the patient's probably adequately resuscitated, right? So SVV, high is dry. And then the percent change, because the value, like the actual unit of measurement is a percent. So that value is greater than 13%. Makes sense? And like I said, I know we've talked about these concepts many times. And if the next like 8 sessions that we do this, you ask that same question, it's fine. Keep asking. That's the only way you're going to keep getting better at this, is just to keep hearing it. And I can talk about it 5,000 more times. I don't care. This is.
I feel like these numbers are the things you just need to like keep hearing, and then eventually you'll be like, okay, yeah,
Exactly.
I remember it now.
And going back, that if you happen to have the device, well, FlowTrack you will have your hands on, right? But if it was something like the Swan, it's like, what are these values supposed to be? And you're just really worried about killing somebody because of the tip, right? But I think having that stuff in my life really cemented these concepts, especially going back to what the pressers did, because you're like, okay, I know this about epi. If I titrate back the epi, I might see a slight decrease in my cardiac output. I might see a decrease in my stroke volume. I might see a decrease in my heart rate, blah, blah, blah. Like all these things. And then you go turn the dial down, and next thing you know, oh my God, all those things happen. I know what epi does! Like, it just, but for me, like, stuff like that excites me. I mean, I know other people, maybe not as like profound of excitement, but I don't know, it makes me happy to know, like, this is what I thought, it happened in front of me, I do understand this, and now, because I do understand it, I can make better judgment on what I could do to my patient next. We do have autonomy in our unit, a lot of it, right? So if you're on 3 pressers and you're seeing something happen, you might argue to your resident, and I say argue in a nice way, like you might have this conversation being like, I know normally you would want me to wean this because it's just kind of like what we do, quote unquote, but I think it makes more sense to wean that because here I'm seeing X, Y, and Z, and it just helps you make maybe a better call on what you're doing for your patient, And I can't stress enough that the more you know, the better you can take care of your patient. It makes it actually easier. Because if it just becomes a bit more second nature for you, you're not wasting time. And in a way, wasting is really not the right word, but you're not taking all that extra time to like ponder and think, because it's just like, boom, it's in there. And, maybe you have more downtime for yourself to actually take a break or breathe or something, because you're not stressing about something that you just can't wrap your head around. And now you're making phone calls to this resident or that person or having this conversation because it's like you got it, what to do next, and at this stage of the game when you're not familiar or not confident or whatever, ask. There is nothing wrong with asking, your coworker, the pharmacist, the actual resident. That should be who you should be talking to if you really were struggling, not the pharmacist, but let's say they just happen to be standing there and you're like, yeah, just curbside conversation here, I have this is what I'm on, this is why they're here, kind of give them a little bit of the storyline and say, like, what do you think, I was thinking about changing this because what are your thoughts? And they might be like, that's actually a great idea, or but you got to also take in consideration, you're like, oh my God, I never thought of that, angle, so having those conversations does not it makes you a better nurse, not the opposite way. Everybody thinks if they don't know something that they're dumb or anything like that. Y'all are brilliant people, you can do it, you're doing it, look where you are, you're running these drips, but now you're just trying to make more sense of it and maybe just now apply this to the next thing. Like, I don't mean to, I want to use this as an example, but the other day Josie out of the blue texted me about something that she learned about PEEP from here and applied it to what made sense with her patient, and like, that's exactly what I'm trying to do for you guys. And so if you take a little bit from this session and you remember just that little bit more, and then we got to talk about it 400 more times, that's fine. Maybe the next time you take that little bit more with you and a little bit more. And eventually it just becomes more and more second nature. You build a better confidence around these things, better advocacy for your patient when you know something. Or maybe like the doctors, they're just not seeing something with this patient, right? And you are, because we stand over that patient for 12 hours and they see that Kodak moment for a second, and you might be seeing something that maybe every time you hit validate, that it just doesn't show. How many times things happen between those 15-minute marks where they went bradycardic into the 20s, but then they were 70 when it captured it. So they were never bradycardic for their whole 12-hour shift. Meanwhile, atropine was given, and so I'm just those types of things. So I think building building better confidence around this. So if you, again, any of these things that we talk about over and over, that's fine. That's fine. Take what you can from here and just try to reapply it, redo it, and get a little bit more and a little bit more. And I'm so happy, like, if you do reach back out to me and tell me about, something that might have come up. It makes me feel great that I maybe have been directing you in the right way or saying the right things, and it was meaningful or helpful. So feedback like that is actually, I would love to hear it. So what next? What do we want to talk about? Or is there something else that you want to talk specifically about what we just talked about, or another topic completely? If no one has a specific idea, Joss had brought up a couple of things that, so she kind of wanted to talk about the anion gap again and autonomic dysreflexia. Is there something else before? I mean, I can mention some of these things. I think the autonomic dysreflexia is not just sort of out of the blue. Obviously, right now we have a patient in our unit that had a spinal cord injury, and so there's probably a lot of people in our unit that just haven't even taken care of somebody like that, only because they're either brand new to an ICU, like a new grad, or maybe just never came from an area of the hospital that ever took care of spinal cord injury, so don't really know too much about it. I will say this is not my forte either. What I can talk about with autonomic dysreflexia is when you have a spinal cord injury, you have nerves that do still come out, right? And there are nerves that are still intact, and but the problem is it's just sort of from wherever you're talking about, like let's say your foot to your brain, there's been a sever of information. So what happens is usually there's some sort of stimulant involved in autonomic dysreflexia. So you're talking about, it could be something where someone just grabs their leg and moves it, or maybe there's a pain, or there's compression, there's maybe there's a temperature change, but something tells the nerve to tell the brain some information. But because the information goes back to the brain, and then the brain is supposed to make a decision, but that whole messaging system got kind of completely torn apart, so now there's a gap and the message can't get back to the brain. It's like this racetrack phenomenon. So the message can't ever get sort of interrupted to tell it to sort of, okay, I got you, you can stop telling me this information. So basically the message goes up the spinal cord, and then it can't really go and get turned off by the brain. So it goes back down, around, and basically you have, how I think of it is that you have this racetrack phenomenon occurring, and you have to treat the symptom in front of you. So, if sometimes like a big one in spinal cord injuries is like constipation, and the patient, they can't really feel their bowels, and if we don't do things to promote motility, they can get constipated, and when they get constipated, it can cause, it could cause a bradycardia, it could cause a tachycardia, it could be distension in their bladder, and they haven't voided because they can't feel it, and they have, maybe they have to be straight cath, and they have 500-600 cc's in their bladder, so it's causing the signal to the brain to say, hey, remember this? But it never gets to the brain, and now it's just going, and so you have sort of this excitement, if you will. I think sometimes we think of it as sympathetic, kind of like storming in a way. But the idea is to treat the symptom that kind of caused it. So if it's like compression, you take the compression off, as long as they're not hypotensive or something like that. Maybe you have to lay their head down, or maybe you have to bring their head up if it's either one of those hypertension or hypotension events. If it's a heart rate issue, you might have to treat that if it doesn't go away by maybe a change in what was the stimulating factor, right? So if it was compression and you take the compression off, and a certain amount of time goes by and they're still, let's say, tachycardic, then maybe a dose of low pressor will be warranted at that point, because the message is like never getting shut off. So you have to do some other avenue of sort of stopping that information that's just sort of going around and around and around. And hopefully over time, that we, as therapy occurs, like they do a great job of trying to retrain the patient, right? I mean, nursing does certain things, therapy does certain things. So, sometimes they're on medication. If they have these, let's say if it's a storm, maybe they're on agents that are trying to inhibit that process from even igniting to begin with. So maybe they're on things like a clonidine or a Lopressor or labetalol or something like that, like routinely around the clock to prevent that thing from even happening in the first place. But sometimes it just happens and you can't, you didn't know it was going to happen. So maybe you got busy with your patient, could straight cath in that hour, and next thing you know, they're having an event because you just got too busy, and that's just the way it is, right? So trying to take out the stimulating factor to begin with, and then seeing if your treatments can be something that you can just do as the bedside nurse beyond medication, right? So like just a position change, does that fix it? Maybe it's talking to the patient and somehow you calm them down, and however that works, it calms their spine down, right? But sometimes it ends up being maybe a chemical involved, whether it's an Ativan or a beta blocker or whatever, or position change. Sometimes they go to try to get them up, and next thing you know, there's an issue with changes in their blood pressure. That's also why, in case anybody didn't know, that's why we wrap the patients, is because sometimes when we change our body position in with gravity, right? So our body responds to that gravity, and things tighten up, things loosen up, and so sometimes that whole process is not working well, and so. Usually the big thing is that it doesn't accommodate for the gravity change, and they get orthostasis. So what will happen is you get them up, and all of a sudden their blood pressure just drops, and then they pass out. So what we'll do for those patients is, and we were doing it for this gentleman that we're kind of mentioning, is an abdominal binder that keeps kind of blood kind of pushed to the core. We'll do some TED hose and ACE wraps to their legs to try to squeeze out as much blood and really divert blood back to the core, so that once we change them dangle their feet and have gravity pulling blood down, that they don't have a huge change in their blood pressure, maybe a little bit, maybe subtle. And then they train them so that their body's like, oh yeah, that's what we do when there's a shift in gravity. So I'm going to, every time you start to move the patient, maybe their blood pressure is really good or actually went up, so they'll test it. And like in this gentleman, we took the abdominal binder off the next day, and he still had a great blood pressure. So the next day we were going to just take his ACE wraps off and just keep the TED hose on and kind of like wean them in that capacity. And this is just from a blood pressure standpoint. This isn't talking about heart rates and all that other stuff. Hopefully if a position change and their heart rate changes and you change them back, maybe that resolves. But if not, like I just said, maybe there would be a chemical intervention such as Lopressor. So something that we don't get a lot of here, at least in our unit. I would imagine that, I would think that SCU3 or the NCC, you guys probably get a lot more, only because it's probably not just a spinal cord injury, but then on top of that, a head injury. So you guys are probably doing a lot more of those things. But, maybe if anybody has anything else to add to that, and what are the things that you can do, just like we just talked about training the patient. So one thing that we're doing is bladder training our patient as well. So we're trying to get them on a bowel regimen. We're trying to get them on a fully clamping. So we're trying to train their bladder to try to see, one, if they can feel it, and two, so that also they don't get overly distended either and have something like that happen. So. And I will say just kudos to that patient because he's doing amazing. But is there anything that you guys from 3 want to add to it, or is that?
Yeah, I feel like I don't know too much about it. I was actually very surprised that in 3, I feel like we don't see that many spinal cord injuries and things like that, which we do, but just when I was starting out, I thought we'd see a lot more.
Yeah.
Which I guess that's good. I mean, it means that they're not happening every second of every day like strokes seem to be.
Yeah.
But no, it's definitely not my specialty, but we have seen them.
Yeah. So really just like kind of treating the underlying symptom that provoked the issue and then sort of training their body around that, I guess is a good way to think about it. So so that was one thing that she wanted to go over. And then the anion gap. So I'm not sure how to... Okay. Does anybody need the drawing? Because I can just kind of delete this real quick. Okay, I'm going to hit clear. And then what I'd like to point out, I think I've mentioned this before. So a practicing nurse for many years, and you know, we always talk about anion gap here and there. Not a ton, which is surprising. I feel like we talk about it more to, you know, these current years than I ever did like when I was starting, which kind of seems weird, but for years I knew there was something about it. I didn't know really what it meant, what it might imply. Also, I knew it was electrolytes, but I couldn't figure out which ones, and I would either look something up in Google or ask Jeeves if you were forever ago, and try to figure out like, oh, okay, it's these electrolytes, and then they would always mash in there some other electrolytes, but it was always like they were part of it but weren't super important, so it would confuse me because then I'd kind of forget about it and then try to apply it to a new patient, and I'd be like, crap, which ones are they? Is it magnesium? Is this one? I don't remember. So I'll tell you, it's funny. You can be a practicing nurse for years and then one day something that you thought you knew and like poof, it's right in front of you. So years ago, I just remember, so this fishbone, the reason why I drew a fishbone is it communicates without talking, right? So we know that it's Na CL. Let's see if I can squeeze it in here. Oh, whoops. I'm writing the whole thing. This is terrible. And then we know we have the BUN, creatinine, and glucose, right? So after practicing for many, many years and always having to resort to going back to the internet, be like, shit, which one is this? I don't remember. I can't keep it in my brain. I was like, oh my God, this one day I don't even know. All the stars align. I look down at my paper and I'm like, holy shit, I've been staring at this since I've started in the unit. It was right here in front of me, and it just, I don't know why I never saw it, never thought about it, never made the connection. But this is primarily your anion gap. Right here in front of you. So if I always tell people who might not use this that you might want to, because one, you can look over someone's shoulder and know what they're saying without having to talk to them, because I can look at their values and be like, their potassium needs to be replaced, you know, without even having to ask. I see these numbers. But also, to me, it's like, wow, there's your anion gap right there, right? So we talk about anion gap, and I always use this like scale in my brain, and I think about pluses, minuses, and just sort of keeping them balanced. And they're never like completely balanced. They're always a little off, and that's where like these like little more incidental like magnesium and phosphorus, these little tiny guys that still do stuff, right? They're important, but as far as the majority of these anions and cations, they don't hold as much weight to this scenario. And so, you know, your body, this is homeostasis. So even with like the slight altered number, not being like 0 or 1 or something like that, being like 7 to 16, you kind of think of that 7 to 16. God, that is a 1. Jesus. Here. So 7 to 16 is being like balanced, okay? So there's two ways to tip a side. I can either add a bunch, which makes this go down, or I could subtract a bunch and makes this fall up, right? Without doing anything to the other side, and vice versa. I can like increase or decrease. So I can add, subtract, add, or subtract. The equation is based on these two and these two. But there are equations that do not require you to have the K, because even the K is not as important as the sodium. So really, if you wanted to, you could just use these three to balance. I just like to use both because it's stood staring at me and I'm going to use both, right? So you can look up the equation for the anion gap, but it's basically taking these and I forget, subtracting, adding these together, subtracting, and then you get this magic number here. So you add, you subtract, whatever. So what you're thinking about is those are like those are the main stakeholders, right? But then what else is considered an acid? So pluses are acids and negatives are bases. So this side are your acids and these are your bases. So outside of this, there are other things that are part of those equations that aren't right there in front of you. So as an example, if I have a normal sodium, potassium, chloride, and bicarb, and I put you in sepsis, I'm going to start to alter your acid level simply by adding lactate, right? That's a whole new plus, lactic acid. So I'm piling up the pluses. That's just adding lactate, right? So that's like adding a bunch here. Plus, what do we know that in a crazy acidic environment such as that, what usually happens? Well, your body tries to achieve homeostasis. It's always trying to do it, right? See a pattern here? It's always trying to do it. And so in this case, you use your bicarb to sort of like offset, to buffer that acid, right? So you use it though. Once you use it, it's gone, and your kidneys cannot replace it quickly. So in sepsis, we start to see a lactic acid. So now we have more of these, and I don't want to do it because I'm afraid I'm going to lose my cursor, but you get rid of these negatives. So this is being forced down because I have all of these extra acids, and we're losing these, so it's like a dramatic like, right? And so you have a loss in your bicarb. So usually when you see patients coming in, their lactates are like, 6 and their bicarbs are like 10. And we know that normal is, okay. (22 to 28). Well, why? Why is that low? Because you're using it. If anybody's ever heard me talk with the vent or whatever, I always say, not exclusively, but just for all intents and purposes for learning in the beginning, that if you think about bicarbs lower than 22, it's an acute process. Bicarbs above 28 are considered a chronic process. Always exceptions for that, right? But in sepsis, we have a buildup of lactate because we are in an anaerobic environment, right? And we're stacking up the lactates, and we're losing our bicarb to offset those lactates, and eventually you just can't produce enough of them. So you're just losing a bunch of the negatives. So right then and there, your number starts to shoot up in favor of this side, right? So the underlying process needs to be reversed for these things to kind of fall back in place. So if you take sepsis alone, what do? Well, we hydrate, right? If you hydrate and reperfuse, you get cells, hopefully as time goes on, out of an anaerobic environment and put them back hopefully in an aerobic environment. And by doing that, you don't facilitate the lactic acid cycle, with the byproduct being lactic acid in that cellular metabolism. So they get better ATP production, better fuel, but you don't have that waste product that you don't want anymore. So you have you have a decrease hopefully in your lactate. So now you're starting to wipe out those. And by reperfusing and taking the lactate and bringing it down, your kidneys have a chance to finally catch up, if you will. So they're trying to catch up to what they were. So this the bicarb that was maybe 10 is now 15, which means now it's getting to 18, and then so on and so forth as time goes on. So you're starting to re-stack your bicarb. and you're trying to shift this whole number back down, okay? So if that concept makes sense, does that concept make sense? Okay, so you're trying to fix the underlying problem here. So what's another acid that this one is where I feel like is the most, like, I think it's because it's in our order sets, that's why we think of it. But I mean, we should be thinking about it other times. But DKA patients, right? Oh my God, is the gap closed? What does that mean? Well, if you understood what I just mentioned here, you have a patient. Is the patient in DKA septic? No. The answer is no. So I have, normal, normal, right? So patient, does anybody remember how DKA works? Just like the real nitty gritty? No. Oh, endocrine issue we can talk about. Love it. See, topics. Okay. Well, bottom line, I'm going to give you the speed test version of it. But basically, you have a lack of insulin. And so the lack of insulin, you have all these problems happening. But what the problem is that in an environment where you have the lack of insulin, you have no sugar entering the cell. And by no sugar into the cell, eventually you excite lipolysis, which is the fat breakdown. And you get really good energy, except not so much for the brain, but really good energy, because glucose, the brain really wants the glucose for its cells. So good energy, but your byproduct of lipolysis from fat metabolism is a ketone, and that's an acid. So if you can't remember that a ketone's an acid, oh my God, I'm so sorry, I see that there's questions. Oh, there's not. Okay, never mind. I'm just seeing this message. I'm so sorry for this chat thing. I'm not very good at it. So you have the ketone. So if you forget, like, ooh, what is a ketone? Is that the diabetic ketoacidosis? Ketone acid. Ketone is, look at your whiteboard. These are ketones. Ketoacidosis. So just like in lactic acidosis, now we have ketoacidosis. Something look very familiar? So you have ketones building up, and it's another acid. And then we say, I don't really want all these acids, so let's buffer that. So I'm going to use my bicarb. So I utilize these. I'm still making these. By the way, in all of this, what is the one thing your body is trying to do to try to help with all of this outside of this piece that I'm drawing? It's one thing that's commonly happening. Your patients will present looking the same in one way, one particular way that I'm thinking. How about that? They're trying to assist with this process. Help it. They're going to help it. I feel like Allison's going to... Come on, Allison.
Breathing?
Oh my God, she's... Yes, breathing. They're going to hyperventilate. So they're going to trade out CO2, also known as carbonic acid, right? Another acid. So every time they are trying to compensate, you see them hyperventilate in these instances. This person, we probably need to tube. This person, just don't do it. Just fix this underlying problem and all will be well. Don't take away their drive to breathe. They're doing a good job on their own. This patient's going to be a while, so they're going to tuck her out, meaning the lactic acid patient. Okay, so this ketoacidosis patient, we have ketones spilling out. So we have a stacking up of the ketones. We have a decrease in your bicarb because you're utilizing to offset what are the ketones. In the meantime, the patient's like chugging along, trying to blow off the carbonic acid to exchange for the ketone, trying to keep the acids about the same, which is still not working. And so they look like crap. And so phase one. Phase one is a couple things, but really, what is the whole thing that started this all? One thing. A lack of insulin. It wasn't present, right? Now reintroduce the insulin, and you're going to slowly, but you are going to try to reverse this whole process. So it's not like you give them a dose of insulin and then boom, stop making ketones like instantly. No. You're taking that whole endocrine problem that you excited that took a little while to go this way to now go back the other way. So in phase 1, you're giving them fluid to hydrate them, and you're giving them some insulin. And by giving them insulin, you're just slowly decreasing their that blood sugar. That's where I was trying to go with that. And by doing that, you're decreasing the risk of cerebral edema, because glucose is a magnet for water. If you rapidly push in glucose into the cells, and being specifically in the cells of the brain, you can create cerebral edema and injure the brain tissue, and therefore cause, change in their mental status, stupor, lethargy, whatever, somnolence. But you don't want to do that rapidly. So phase 1 is really just trying to give them insulin and take them from whatever crazy blood sugar they were, whether it's like 800 or 500 or whatever, and bring them down to below 250, right? After that, you might have them between, I think they like, I want to say 150 to 200 or something. I forget their range on the glucose. This is just phase 2. Don't worry about the specifics, but you're just keeping them normal now. Now you actually give them sugar, and you're like, wait a second, isn't this whole problem because they had a high sugar? No. The whole problem is because they didn't have insulin. They just had a high sugar because. So now the thing that's fixing this whole problem is I still need to give them insulin. So now I get them to a normal blood sugar. If I do not give them sugar and I keep giving them the insulin, eventually their sugar is going to be 0 and dead. Right? So now I actually got to put them on a sugar drip so that I can keep giving them the insulin. So now you're going the opposite. The whole problem is I need to give them insulin. Sugar's normal. Now I want to give them sugar so I can keep giving them the insulin. That's what's going to fix this. So now by giving them the insulin, the message is being heard, just slow response. Hey, glucose is now going into the cells. So guess what? Oh, you know what? I really like this because I rather eat this than the fat, although the fat was good. But if I eat the sugar, I guess I don't need that fat source. So therefore, lipolysis will slow down, which means ketone production will slow down, which means the pluses will slow down. So you're not going to have as many. And then so this is coming back to normal, right? I might have one of these, but now I'm back to 3 of these. But slowly, because your bicarb was crap, it was probably 5 when they showed up at the doorstep, right? The bicarb was low. So what's going to happen is now that I've slowed down or halted that production of ketones, I'm giving the kidneys a chance to increase their bicarb, replenish the bicarb, and by doing that, you're going to increase. See how this works? Increase those negatives. And hopefully the gap is closed, meaning it came back to normal. There wasn't a door shutting. Right? So the gap that was probably 30 because they had ketones this much and bicarb down to here, you have dropped the ketone production and you've improved slowly the bicarb. Okay? So does that make sense? Okay. I'm getting a yes down there. Love it. Okay, so let's take in one more that I feel is kind of like a common thing. I love just talk about this. So we give, has anybody given normazoline before? No? Wrong, you all have. That's code for normal saline. It's just a funny way to say it. Normal saline, normal saline, where I want to draw this. All right, so your sodium in your bloodstream, I forget, was it like 135 to like, let's say 143 or 145, somewhere around there. I forget the exact. This won't really matter. Let's just say 145, just because. Actually, 133, I believe, is the low number. It's 133. And then your chloride is... Interesting enough, I never remember the bottom number. The top one is 108. Something, it's like 94, 92 or something to like 108. I know the top, I just don't remember the bottom. Okay, So that's normal. That's blood. That's your blood. So if you look at normal saline, there's 3 things in that bag. Just 3. There is sodium, chloride, and H2O, right? So there's water, there's sodium chloride. People say salt and, no, salt is the big word for 2 things, right? So I say that all the time wrong. I'm like, salt, I mean sodium, because people think sodium and salt, right? Because we always say that to like people who have CHF. Don't eat a lot of sodium. Don't eat a lot of salt. But you have a 1-to-1, right? Because it's a compound together. But to keep the osmolarity normal, you need, in that bag, 154. That means you cut it down the middle, you take the sodium and the chloride and move them side to side, separate them. You have 154 of one and you have 154 of the other, yes? Makes sense? So when you have normal saline and you're giving them a lot, eventually 154, does anybody want to answer this? Is it less than, equal, or greater to 145? Greater than, right? So same thing with the chloride. Is 154 less than, equal, or greater than 108? Anybody want to take a shot at it? It's greater than, right? So when we give our patients normal saline, normasaline, it really should be called abnormal saline, right? It's really not normal. We're giving them this crazy amount of sodium and a crazy amount of chloride. And so when you pump this stuff into patients, the only reason that they got hypernatremic is you guys. Every one of you. Never me. I never did it. But you guys only. Because you're new. No, just kidding. All of us. We are responsible, right? It's like when you go to a restaurant or you're home watching a movie and you eat like a giant plate of nachos. What's the first thing you want? Something wet. Usually we like to say water. It's probably a margarita, but something wet, right? Because we want to dilute our bloodstream, because all of a sudden we've absorbed all this sodium and our bloods, or our sodium, or salt, our sodium went up, and we need to dilute it back down. So I think of the bloodstream, and I use this concept a lot to talk about different things. So I use the bloodstream as like a package of Kool-Aid. Right? If your bloodstream is like, if you were to rip open one package of Kool-Aid, I believe it's 2 quarts of water. You pour the 2 quarts of water in that one, and you got perfect Kool-Aid. Okay? So that's like having all of your numbers be perfect. But if you're really dilute, you put 3 or 4 quarts of water in there, you're going to taste gross, and all your numbers are going to kind of be low, right? And if you take that, maybe you only put 1 quart of water in with that package, and it's really concentrated, very sweet Kool-Aid, yes? So when we're talking about this concept, it's like, okay, I ingested a bunch of salt, right? So I have sodium and chloride. They both rose, especially that sodium. And I have this feeling like, I need to drink. I need to drink to bring this number down. I got to dilute it. So I went from really concentrated Kool-Aid, and I'm trying to bring it back down to normal Kool-Aid. So I got to add water, right? So what do? We drink it. But our patients are like, water. What is their chief complaint? I want a sponge. I want a glass of water. No, you can't. Sorry, you're in the hospital. You're in the vent. You get this. You can't. No. And they all are just like dying of thirst. Congratulations. We all did it. I will own it a little bit. I did it too. Right? So we're pushing their sodium levels up. And what do we always want to do? We want to drive it back down. So we can do that in one of 2 ways. Ultimately, we're going to need to give them one thing, water, right? I need to give them water to bring it back down. So if I can use their gut, I use it in the form of free water through their auto flush on the kangaroo pump. But if I can't use their gut, then the next best way is to give them like a D5 agent, something hypotonic, so that as they metabolize the D5, then they're left with just water, right? So they chew through the sugar, they utilize it, and then they're left with just water. So that means you've just given them water, which is what they needed to dilute their bloodstream back down. So that's how we kind of help to manage that. So if you're talking about anion gap and you have too many, hypernatremia, you might start seeing their anion gap go up a little bit, right? There's that one right over there. You just add a lot of pluses. But another one that we don't think about as much, I think. I mean, I know physicians do, but I definitely try to teach nurses too to think about this, is that especially if we're giving a lot of things in sodium chloride, like a lot of drugs, maybe they can't be in D5 because they're only compatible with normal saline or whatever. We have to think about a lot of not just like the maintenance fluids or then the boluses that we might be giving, but then the drugs that we keep like continuously infusing or periodically infusing. But maybe it's a lot of sodium chloride, so maybe that's why they have so much sodium in their system, and then their chloride's rising. And their chloride, you pee that out, maybe you poop some of that out. Obviously you use it, but the chloride, if we start to like really push that level up, well, here's this interesting phenomenon about this. So here we have chloride being your negative and your bicarb being negative. They're both negative. So if you start to push someone's chloride level past 108, what you then start to do to the kidneys, or the message that's heard, is that, well, if I want homeostasis, right, I want to achieve that homeostasis like we're always trying to do, then the body starts to say, well, if you're increasing so much of this chloride and I can't really get rid of it well or quickly or efficiently, then the next best thing I can do to keep the balance, remember this balance here, is I will slow down the production of this guy right here, so that I don't have, if I have a lot of these, then if I slow down the production of this and make this number go down, that will keep this balanced, right? Does that make sense? So what hyperchloremia does is it induces a metabolic acidosis, hyperchloremic metabolic acidosis. And that's one thing to be kind of mindful of, is that, maybe we all look at the sodium and we're like, our eyes gravitate. It's the first number you see on your BMP and your CBC or CMP. And you're like, oh my God, my sodium is like 148. And we're like, let's get an auto flush. But has anybody then looked at the next 2 lines down and was like, oh, the chloride, it's 110. Oh, they're septic. Oh, they have a lactic acidosis. Oh, their bicarb's falling because it's offsetting that lactic acidosis. Oh, their chloride happens to be 110. Aren't you just like throwing gasoline on that fire right now? So you're telling, like, you're already having a lactic acidosis and you're dropping your bicarb, right? But then if you keep them hyperchloremic, if this is a scenario, I'm not saying this is like every patient by any means, but a scenario might be that you might have somebody who's septic and they have a lactic acidosis going on, and already you're dropping your bicarb to offset the lactate, right? But then let's say the drug you gave them, when I said volume for sepsis, right? But you tank them up with nothing but sodium chloride or mazoline, right? Abnormal saline. And you just shoot up their sodium level, but you also shoot up their chloride level, then eventually you might be telling the kidneys to also halt production because the chloride level is so high that you just added a resistance to this coming up, basically. Does that make sense? I feel like I can only see Josie and Allison. You're saying yes, but you look like you're puzzled. I feel like, are you missing something?
I think I did miss something for a second there.
Okay.
Why would the chloride being higher, why would water being added and the chloride being higher be bad?
No, not water. So the volume you're using, right? Isotonic solutions.
But did you say like adding in just a flush would be the wrong answer?
No. That's to offset the sodium I was talking about. So,
okay.
So when someone's hypernatremic, what do we always do? We always, because you're getting that thirst, right? So like you and I would run to and get a margarita, like I said, or hopefully a nice glass of water, and really try to take the sodium we just ingested and dilute it back down. But when it comes to the chloride, it's not as easily, like, I guess, manipulated, if you will, as much as the other things. So if you have somebody who's trending up with their chloride level because you keep giving a bunch of sodium chloride or things that end in chloride, then eventually that chloride level being high will actually tell your kidneys to slow down the production of bicarb so it can keep that side balanced. right?
Right.
The negative side balanced. But what you've just done is you've created a metabolic acidosis, right? The lack of bicarb is metabolic acidosis, an acid,
Okay.
because I don't
So what
have
can we-
enough base.
What could we do instead? Would you use like LR?
So you try to find things that are appropriate. So so a big one is well, water, of course, absolutely. But then so sometimes you look at like the drugs, like, hey, I'm running this presser. Can this presser be put in D5 rather than normal saline? Because a lot of drugs, they're usually prepackaged in something. So pharmacy, if you have this issue with a lot of like, usually with sodium, not all the time, but I would say majority of the time, sodium can be corrected with either the auto flush or just something as like a D5 drip. But then sometimes it's like a continuing chronic problem, and also maybe the chloride's also this piece to that puzzle. So then it's like, hey, pharmacy, can you try to like take anything that they're getting, whether it's like Vanco or this antibiotic or this particular drug or that presser or whatever, and put it in D5, as long as obviously it's compatible. Sometimes the answer is no. Or sometimes it's not just, it's really not a lot of volume. Let's say it was like your, you know, you were on like Levophed and you just couldn't get them off 0.03 and that was like 3 cc's an hour. Is that really going to be the thing that's making and breaking this patient? Probably not, you know. But trying to, you know, so the other things that can help, only if it's appropriate, right, would be like if you could diurese your patient and drag out some of the sodium and the chloride that way. Or, not that I would choose this to be your option, but let's say they had a lot of diarrhea, well, you might lose some chloride that way. So that might help bring it down. But the problem is that you lose bicarb too in that scenario. So the treatment, you know, one of the bigger treatments is really just like not delivering the chloride, and for speaking solely of the chloride, and then obviously adding in water just like your sodium, right? So, but the thing to be thinking about is your chloride level being high, because sometimes you can correct their sodium down, but maybe their chloride's still elevated. So I've gotten the sodium checked off the box, but my chloride's still high. So that might be telling the kidneys hold the production of the bicarb so I can keep the negative part of my anion gap, right? So like these two pieces that I keep looking at on the screen, and I know you don't see what I'm doing, but you look at these negatives and trying to balance within themselves to keep that teeter-totter stationary, right? So if I'm building up the chlorides, then maybe just by subtracting some of the bicarbs, I keep that even. But I've lost bicarb to do that, and therefore I have now a metabolic acidosis simply because of the chloride being high. So hyperchloremic metabolic acidosis. To me, it was a very interesting thing to learn about. I was like, I never thought of that. I just looked at sodium, sodium, and sodium. And then when you go back and you look at the different things that are in these bags, I only remember this one just because it's easy. There's only 3 things, but the 154, right? Think about how much sodium chloride we give patients. And then you guys are the worst. I mean, you give 3%. We're only giving 0.9%. I don't even know what that is. But I actually
hate water.
right. But I gotta ask:
serious.
have you now hearing this? Go and keep an eyeball on your patients' labs, especially those ones that are like really sick and that you're having to really push their sodium levels up with like the 3%, and just see like what are their chloride levels doing, and see like, are you deranging the bicarb that way? You know, is it becoming a huge problem? Because you don't want to give these guys water. You want them to. Water is bad. Why is water bad for those guys?
So scary.
But why? Why is water bad?
Causes edema.
It causes edema. It's going the opposite direction you want it to go.
Yeah.
So now you're like, what do you do for that? So now you ran
I
into a
will.
whole
I'll
new
keep it on
problem.
the chloride and I'll get back to you.
Yeah, you know, it's interesting because I'm saying this now and thinking we did have some of those complex patients before, before it all went to SKU3, and I can't say I don't know if I knew these concepts then, so I can't say I actually kept an eye on it then and noticed, but now understanding it but I don't get that patient population, it'd be interesting to be like, oh, keep an eyeball on those 3%ers or even the 2%ers, when you guys give that. I don't know if when you guys give that 24.7 or 23.7%, 23.7, when you like bang that puppy into them, maybe it's like a concentrated dose one time, but I don't know its like effect you know, usually what we're doing, right? Sodium chloride is like around the clock, day in and day out, you know, versus like a one time here and a one time there for like an ICP problem. So I don't know what its ultimate effect is like that. I mean, I know it probably does some things, right? Because your sodium's going up, but for that, I don't know. I don't know. But it'd be interesting just to kind of keep an eyeball on it and then hearing about it later. So yeah, about the 3%ers and 2%ers for sure. So yeah. Anyways, is that help shine a little bit of light on it? The other electrolytes like the mag and the phos, it's like they're all there, but they're minuscule compared to what these components are. So that's why they have an effect, but not a dramatic effect like your sodium, your chloride, and your bicarb. Even potassium's not quite considered that big of an effect. So if you Google the anion gap, just equations, very simple, but you'll see with and without potassium. So it's either sodium with bicarb and chloride added together and then them subtracted from each other, or you'll see it with potassium, sodium added, and chloride and bicarb. So you can take out the K and still get pretty much the same number for your anion gap.
Can we talk a little bit more about lactate while we're on this subject too?
Yeah.
Like, I know we get all stressed out when it's above 2, but can we like dive a little bit more deeper into it?
Yeah. So anaerobic metabolism, it's an environment obviously with lacking oxygen. Interesting enough, the Krebs cycle doesn't actually use oxygen, and I'm kind of like trying to revisit this and like understand this a bit more on my own, because I've always thought of this as the metabolism itself is utilizing the oxygen in its equation, but it's not. It's a transport. It's electron transport. I forget how this works. So even in an oxygenated environment, the Krebs cycle itself is not using oxygen, but it's used as a transport carrier. So you yield more energy. You use like a little energy to make a good amount of energy. So this is where like ATP comes into play, and you yield all these different byproducts, and like CO2 and all this stuff comes in and out, and it's a very complicated thing, and I don't have my finger on it at all. But the little that I understand about it is that, you know, the yield is a good yield of about 36 ATP at the end of it. So it's a little energy that yields a lot of energy. So it's efficient, right? But then in the anaerobic environment, there is the lack of that oxygen. So it uses a different system called the lactic acid cycle. And so it's a similar cycle, but obviously oxygen is not part of this. And ultimately in it, you yield 4 ATP. So it's kind of like using a lot of energy, but only to yield a little bit. So it's like not the best, it's not efficient. And its byproduct is lactic acid. So through that metabolism, you yield this acid, and when that's pumped out into your bloodstream, the environment, the pH drops, of course, right? Hence adding more acid. So, you have a normal pH, you add a bunch of acid, and therefore you drop your pH. So in sepsis, you get this shock state, this vasodilatory state. So your SVR plummets and you lose volume, and you lose volume for 2 ways. You lose volume because the pipe remember the circle that I showed, if you have a pipe this big and it's fully filled, and now I magically turn it into a pipe this big, and I saw that same amount of volume, that pipe isn't filled anymore. So the pressure in it is dropped, right? So you have vasodilatation, so that's poor perfusion. And then also compounded with that is you have at the capillary beds, you have that permeability. So you have the stretching of those vessels. And when you have the stretching of those vessels, water is now starting to leak out in third space. So I have dilatory and loss of water, and so ultimately I just have a really bad perfusion. So these cells are trying to, stay alive, and so they're flipping from this poor perfused area state, right, of with oxygen to now without oxygen. And so those areas start to try to stay alive, yield fuel for themselves, and the ATP is what they yield, but unfortunately they spit out lactate, and then that just kind of keeps them going. So just like when we said DK, what's the problem? The lack of insulin. Okay, so you want to fix this whole thing, you introduce the insulin. So in sepsis, what is the problem? Well, chicken or egg theory. Is it the bacteria that are killing you, or is it your response to the bacteria? You guys can answer that. But you have this vasodilatory state secondary to some intruder. And the intruder could be anywhere. It could be a toe, a spot on your toe, abscess inside. It could be a tooth. It could be on your heart. It could be in your lungs. Whatever. You have something igniting this whole process, and that process is your reaction is like this unwanted but in a way necessary like reaction, but too much response. So you've gone from SIRS to overwhelming sepsis. Like everybody sitting here who's ever been sick and like really sick, you've been septic. You were past SIRS, you were septic. You just weren't overwhelmingly septic, so your body was able to maintain. You're probably hypotensive, you felt lightheaded, dizzy, probably only felt good when you lay down, shocker, gravity pulling blood, right? Like those things make sense when you step back and think about it. But you only think of patients in the ICU as being septic. But no, it's just that your body could finally handle it. These guys eventually, like, they just get tipped over that precipice, and now they're so vasodilated that their whole shock state is overwhelming, and now their body's trying to do this and compensate here. They're breathing really fast because they're trying to exchange carbonic acid because of the buildup of lactic acid, and so that's what's causing that breathing pattern to happen. And meanwhile, their bicarb is being utilized. So guess who wins? The lactic acid if left untreated. So what is going to reverse this whole thing? Perfusion. Really the antibiotic, right? So kind of really two things I think of. It's the antibiotic that's going to destroy the thing that's setting this whole thing off, right? Whether it's the actual bacteria or the reaction to the bacteria, again, you can chicken or egg, but the thing that's there is what's exciting this whole thing. So let's get rid of the bacteria. So that's why right away, within that first hour, antibiotics. When it comes to treating those symptoms though, the first drug of choice is volume, rehydrate. If you can, because remember, I always kind of say, and I am guilty of saying this incorrectly too, blood is an umbrella word. It's not a red blood cell. We think of it as the red blood cell, but blood is the umbrella word for a lot of stuff that happens to have a red blood cell. Blood is plasma, electrolytes, clotting factors, drugs, but it also has water. And water is that vessel for your blood cells to go somewhere. So if you're profoundly dehydrated, you had, shock, and don't have a lot of red blood cells, you need red blood cells to be replaced, but you need the thing that brings them there. So in this, if you think of septic shock, are they having a hemorrhagic event? No. Their blood vessels haven't gone anywhere. They're still there. It's just that the vessels, the cars that bring them around, they're gone. The water. It's third spacing, and your vessel is this big, right? So if I fill you back up and I deliver you a bunch of cars that your cars can drive those red blood cells around, then you're going to get oxygen in those spots, right? So it's not a lack of oxygen because it's not in the bloodstream. It's just that I don't have the cars to bring them there. So I need the cars to bring them there. So if I can bring the car, or if I can put the car back, right? So this is the LR, the normazoline, the Normasol R, any of those isotonic fluids that when I deliver it, it stays where I put it. Now the red blood cells have a chance to go to where they need to go, hopefully reintroduce perfusion, so prevent ischemia or fix the ischemic events that might be occurring. And then I've switched from the anaerobic back to the aerobic, which means, again, just like the DKA analogy, it's not fast, right? It's not like, boom, switched it off. No. It might be a process that's just slow, right? But what I'm doing now is I'm hopefully slowing down the anaerobic metabolism, which means I'm having less and less lactate being poured out, which means the pluses over here are starting to kind of come back down, and my minuses are down here because my bicarb is trash. It's been used, and it can't be replenished fast enough. So what they do, or what your body will do, is like as you decrease that lactate, it's starting to kind of build back up the bicarb, and eventually, hopefully, again, homeostasis. But you've tipped yourself so far in one direction because you've lost bicarb and you've added a bunch of lactate, right? So you got to stop the underlying problem, which is the bacteria and your reaction to the bacteria, right? So I got to kill the infectious source, but I also got to stop your whole like reaction to it. So hopefully that's enough. And then the question is do you need a steroid to help, participate in that process? That is stress dose steroids, and that's that's like a different problem. So this is like if someone's refractory to your therapy. So we're on, one pressor, now we're on two. Are we up titrating? Now we're on my third, or were we on just a little bit? Now we're on a lot of that same drug. So whatever we consider, if someone's kind of like, they could be adrenally insufficient, or if we kind of just like know they are, maybe this is a person that takes prednisone every day. You gotta give them something. Their body was used to having 5 or 10 of prednisone every day or whatever. So we gotta give it back, right? So a steroid might help with that inflammatory process, and also dragging in sodium, and that way you build back up a water volume into your bloodstream. So it helps with that. So glucocorticoid, mineralocorticoid, also stuff I just was kind of like sorting out recently in this last week, had a different understanding a little bit of that, so that was helpful for me, and actually is a great opportunity to share with you. But all of those solumedrols and hydrocorts, those are actually both. I always thought of them as being glucocorticoids and fludocort being mineralocorticoid, but they're actually both. It's just that drug themselves has a certain percentage of one or the other. So what's interesting is hydrocort is the thing that's most like your adrenal glands, and solumedrol has more glucocorticoids. So hydrocort actually has a lot more mineralocorticoid, which is your sex hormones, but also is your aldosterone. So it helps with dragging back in sodium, and we know with sodium goes water, and so with water you have retention of, right? With the retention of sodium, you have an increase in water, which means you hopefully have better intravascular volume as time goes on, right? Plus the decrease in inflammation from the glucocorticoid part of its function. So take that drug, because this actually came up this week, is why solumedrol versus like hydrocort, and I was like, they're both glucocorticoids, but that's not true. Actually, they're both. It's just the percentage of what they do. And so solumedrol is mostly, I don't know percent wise, but mostly glucocorticoid, still mineral, but mostly. And I guess Decadron is all glucocorticoid, no mineralocorticoid. So going back to the lactate, is that you need to stop what is driving this to decrease that. So you need to kill the bacteria and help with the inflammatory state that's killing this patient, right? So hydrate them, squeeze them, steroid them, kill them with vancomycin, which is like our typical, and hopefully as time goes on, lactate production, which is your acid, drops, and bicarb replenishment starts to increase, and you're back to homeostasis and having somewhat of a normal pH or a normal pH. Does that help, Josie? Or is there something else? Is there more to it that you're thinking?
No, that's what I was thinking about.
Okay.
Yeah, because I was just thinking like we get a patient with a lactate of 6 or 7, like what are first things we do, stuff like that. So that covers it.
One more thing just to throw in there is you also have to think, where is lactate metabolized? So like right now, if I asked you to jump up and down for like a minute, your lactate will just shoot up normally because you're using your muscles and you're probably going past your VO2 extraction. So like your dissociation curve, you're probably like not extracting it as efficiently as you could. And so eventually you start to produce lactate because now you flipped yourself. This is where like aerobics, when we talk about exercising, you're trying to build up a tolerance, trying to kind of get your body used to a certain what's the word I want to use? Like put them in an environment that they don't like, right? But then kind of get them accustomed to it, and then like okay, we got this. We know how to extract oxygen here now. Okay, now we're going to push you a little bit further and a little bit further. So like we're conditioning your body, right? So when you're not super conditioned, I get you to like move for like 5 seconds. I mean, we got a pandemic weight over here. I move for 5. I go from here to the stairs, and I probably have a lactate that shoots up. But your liver will help to decrease that. It'll break it down. It actually turns it back into a bicarb, which is interesting. That's where LR can be tricky. People are like, oh, their lactate's high. And I'm like, ooh, but if their liver's okay, that actually will work to their advantage because that will actually increase their bicarb by the metabolism of the lactate in there. But if your liver is damaged, or you're in hepatic failure at baseline from drinking and cirrhosis, or a viral issue from like hepatitis, and you have destruction of your liver and it just doesn't work well to begin with, or maybe it's exacerbated by a hypotensive event and they have shock liver or just shock liver, whatever. But the problem is like maybe your liver is just not functioning as well as it could be. That might inhibit lactate from being like cleared. So sometimes you have to take a patient, like especially these liver patients who come in with cirrhosis to begin with, their lactate on every day walking around at Walmart might be like 3 or 4. And that's just them because they just can't clear it, but then they've adapted to that. Their bicarb production is probably shot up to compensate for the chronic elevated lactate, just kind of like a COPD would with CO2 levels being just chronically high, right? High bicarbs equal chronic, conditions kind of thing. So that might be a patient where you have to consider, yeah, maybe their lactate went from 15, now it's 5, but 5 for them might be like your and I's like 1, right? Because that's just where their liver is at, If it's not something that's like a chronic problem for them, then maybe they just need some time for their liver to heal to be able to clear it a little bit easier. So in those situations, maybe not giving them as much lactate, so LR might not be the best choice, and maybe the saline. But then we come to how much chloride do they have? Did we just cause a hyperchloremic event where now they have a lower CO2 because, it's like, it's so fun and fascinating, right? What do? You know what you do? You put your hands up, you walk around in circles. I don't know. I could do all of them and none of them, and I just get to the same point. So hopefully that's helpful with the lactate. And then putting this aspect to the anion gap and putting it into perspective for like the things that we kind of, I think, deal with mostly. Which is your septic shock and lactic acid, and then you have your ketones from ketoacidosis, and then you have the flip of that, which is now you have just high chloride levels that are totally demolishing your bicarb. And then if you were to have any of those two that I previously said and compile that with the chloride, that maybe all of a sudden you're exacerbating what other problem they had and making it worse. In other words, you have septic shock and you have a loss of bicarb, and I'm making you hyperchloremic, which is telling you to slow production. So it's like bad, all bad, all bad. And then I think a follow-up question I commonly get would be like, when do you use like a bicarb drip? And I think bicarb drips they're sort of like a Band-Aid, right, for the problem, but the Band-Aid could be applicable, and everybody has their own take. And nephrology versus like your actual critical care services, whether it's surgery or medicine, they all think a little differently. But I would say that a common way to think about bicarb infusions being like warranted, or at least how I've perceived it to be warranted, would be when the patient is on multiple pressors, and just like you would think about your steroids being refractory, because there's a point where I've said this before and anybody's ever heard me, is like, would you want to be acidotic or would you be alkalotic? And the answer is, if you had to choose, be acidotic, because you actually extract oxygen more efficiently based on the dissociation curve. So it's good to be, and that's why we do aerobics, right? You kind of push yourself even further and further. But there is a point where then acidosis isn't so good. And it's not so much from just the oxygen standpoint. Now you're looking at really the enzymatic processes and like the way like electrolytes go in and out of cells. So the electrical dynamic within a cell changes. So what that tells you is that sometimes when your patient's so profoundly acidotic that they don't really react to their pressors as much as you think they would. And they might be on a ton, and then you alkalize them, and I don't mean get them to normal, just give them like 1 amp of bicarb. So as a scenario, let's say your patient had a pH of 7.0 and you gave them 1 amp of bicarb, and let's say you could measure that and they went from 7.0 to 7.1, which is terrible still, right? That might have made their blood pressure shoot up, and it's not because you gave them 50 cc's of a bolus. It's not a fluid bolus. That's you alkalize them, so all of those processes are able to work that much better in a more alkaline environment. Still acidotic, but you've pushed them up, right? And then it wears off and everything kind of falls back. So in those patients, and I always say everybody says something different. I cannot tell you what the exact number is. I don't think there is one, but like 725, I feel is like our magic number to consider. Like if you're below 725, we really need you to kind of get to 725 or above. Some say 720, some say 728. I just kind of say 725. It really doesn't matter. Just pick that number. Kind of consider, are they so acidotic that they just can't bite on these pressors? They can't do what they're supposed to do because the enzymes in their bodies aren't working. The electrical conductions aren't happening. The cellular processes, they're not happening the way they should. And you alkalize them, and all of a sudden, holy crap, they're on much less pressor support or something like that. But it's not, maybe it's like I said, the Band-Aid. But maybe as you're fixing them and as their ischemia is resolving, then you're changing that whole process, and then you can titrate back or even off your bicarb. So it was like your Band-Aid to bridge from here to here. So it's like effective that way. But it also is sodium bicarb. So you have to be careful your sodiums don't go flying up. This is why amp after amp, people get caught up on, well, it's bicarb. But it's sodium bicarb. It's not that thing over there, HCO3 negative. It's got to be compound. It's a compound, right? So it's sodium chloride. So now your sodium keeps shooting up. And maybe now you have a sodium of 150. Oh, great. Now I created a whole nother problem trying to help them get out of their acidosis, right? So again, what do you do? But just so people know, D5 with 3 amps of bicarb. D5 half sodium bicarb. I forget if that's the isotonic version. D5 3 amps of bicarb, sodium bicarb. Oh, God, I can't remember now. Shoot. It's been a while since I ran one. I'll have to think about that. But anyways, it's always that sort of like generic liter that they do make, but basically they're taking that drip and they're just injecting 3 amps in there. So if anybody has, think about that as a bigger picture, is that, you're used to walking up and slamming an amp in, that's 50 MEQs. And now you're looking at a whole bag, a liter, having to run all the way in to get 3 amps. So about a third of the bag is about an amp of bicarb. So by the time they've infused one whole bag, they've received 3 amps of bicarb. And hopefully you've alkalized them back up to something that makes them a bit more normal. Not normal. No one needs normal. And hopefully the vent is being, manipulated in such a way to also help to keep their pH closer to normal. At least like 725 or above, like somewhere up there. Make sense? All right. Well, let me hit this button. Get you back to here. Oh, huge version of me now. I'm happy it worked for you. So sorry that these are late, that I'm reading these. You're making my Thursday so much better. I don't know what you have, Gianna, on Thursday. So whatever Thursday is, I hope it goes well. I'm glad I could help. Is there any, we're at 1 o'clock, so is there any other questions, or is it a wrap?
Hey Mark, these are so helpful. I have not been able to get my head around a lot of this. I'm 2 years in now, and just the way you present it and the way you explain it has been really well done. I appreciate you taking the time to do this.
Oh yeah, no worries. Thank you for the feedback too. Yeah, and like I said to Ashley earlier, and it goes for anybody on here, like I don't know everything. I don't have a special schooling. I don't know all the answers. I can make educated guesses. I'm happy to try to take the information and try to find the answers and get back to you guys, so it doesn't feel like it was just sort of left unfinished. But there's things that you're going to hear that you won't understand, and it's okay to ask the same question. I don't care how many times. So if we have the same exact conversation the next time around, that's fine. It's for your benefit. It's for my benefit too, because I can figure out how to say things a different way. I can think of, you guys ask me questions I don't know. Yeah, you're welcome.
This has been fantastic. I really, like, the couple of things you've even put together for me today have made a huge difference in how I'm going to practice.
Great.
Thank you so much, Mark. It's beyond helpful to like be able to learn outside of the hospital because we learn still so much. I learn like at least 100 new things every time I walk into Maine Medical Center, and it's stressful.
Yeah.
But it like I learn like some things, and then coming here and being like, oh, actually, what the F did I just even see? It like ties it all together and like fills in the like missing gaps.
Good.
So
Yeah.
thank you so much.
Yeah,
When's the next one?
Oh, Alana's gonna post it. Give me 1 second because I don't remember. Sorry. Where is it? If you want to write this down, so because we filled out our new schedule, I can go in advance a couple months now. So February 3rd and March 3rd are both going to be Q&A sessions, and February 10th will be my next vent class because I'm alternating months, and March 11th will be my hemodynamic class. So the first
February 3rd and March 3rd are Q&As. February 10th, you said,
10
is your next event.
is
And do you know, because we've done it before already, do you think we get paid to do it again? Because I feel like the
I
vent
think so.
changes, I swear to God, every time I look at it.
No, personally I think so because it's not. I don't think it was meant for just like. I mean, it's for anybody to go at any level. I think it's the fundamental aspect. So it's geared towards people who either have no critical care experience or they're from another floor, already a nurse, or they might be new grads such as yourself. But also just like this, if you hear it one time, you're not expected to just walk out and be like, okay, pro. No, like if you need to hear it again, I think it's come. Do they pay for it? You have to ask them. I think it should. I mean, I know people who go are getting paid. It's if you're a reoccurring member, but I think you're showing them that you want to learn. You don't have it all. You want to hear it again, and that's okay. And I think I think that's respected, and I think that should be paid, and that's up to them. But
So it was February 11th and then March 11th?
hold on. It was February 10th was the vent.
Okay, there we go. Sorry.
And March 11th was my hemodynamic class. The first hemodynamic class is the 28th of this month. And basically I'm doing vent, hemo, just alternating each month. So there would be a Q&A every month, and then those two classes will be all opposite of each other. And then there might be some other classes to come if, depending on the needs and whatnot. And I know Critical Care Academy is coming sometime. I don't know when. I heard spring, but I who knows? Who knows? So, all right. Well, unless there's anything else, I want to thank everybody for coming, and I'm glad you guys did come and learn something. And shout out if there's anything that you experienced or if you have questions. And like I keep saying, if there's things along the way that you want to talk about in one of these, just try to write them down somewhere where you just keep, like, that way you just kind of remember. And yeah. All right.
Well, thank you so much.
Yeah, you're welcome. Have a good rest of the day, guys.
Bye, thank you.
All right. Bye-bye.
Thank you.
Yeah, you're welcome.
Okay.